comprehensive and quality eye examination. Because this may seem like a moot point, but then when you have an infra in the rural areas, you are not able to get ophthalmologists to go and work there. So you're going to put some technicians or ophthalmic assistants, and that should not be an excuse for a different or a lower standard of care. So this we had made a sort of a design principle that is not negotiable. The third important thing is, again, in the last mile, kind of following through with the advice that you give, to buy medicines, glasses, or to get surgery done is not easy. If as providers we don't design for it. If you just give them a prescription, then it's as good as not giving them anything, because they can't get ophthalmic medications or glasses in a remote area. So again, the design had to close the loop. And of course, when you have infrastructure that is out there, out of sight, run by a technician, you really have to have systems and processes to manage. So this was the design principle. And then this is what we came up with. This was done in 2004 onwards, when there was no internet available in rural areas. So we established our own broadband connectivity by setting up towers and things like that. So in a rural area, if the patient walks in, they would pay 20 rupees, which is good for 3 visits. This is a typical center. And the technician does a comprehensive eye exam, checks for glasses, and then we also do some opportunistic health screening, blood pressure, diabetes. We check intraocular pressure, do a detailed eye exam, very much like a eye doctor would do. And then all the data is entered into a electronic medical record in the cloud. And so the technician then briefs the doctor in real time as the patient is waiting. And the doctor again interacts with the patient. And then the doctor also is able to see the medical record. The doctor sends the prescription. If it is for glasses or medicines, they can get them right there at the center itself. So this lady who walked in probably in about 40-45 minutes, now her problem is resolved. She has a pair of glasses on her face, and then she gets back to work. So this is the model that we built. And then since everything was digital, we could actually monitor this quite well. Today we have about 95 such centers in Tamil Nadu, Pondicherry, covering close to 8 million population. Of that, little more than 2 million unique patients are registered at the center. And overall, we've had about 5 million visits thus far, some from outside the service area of these centers. So which means we have covered more than 25% of the population, which, if you look at eye care, would kind of indicate that this is close to universal coverage for eye health. Now, this is the holy grail that all of us are trying to reach. Now, how do you provide care to everyone who needs it? And then again, whatever we prescribe, glasses that we prescribe, 91% uptake. Similarly with medicines, if it is surgery, what we're able to track, about 2/3 have got operated and so on. So we're able to also not only give coverage, but also make sure they get the care that they need. And we also realized that these last mile infra, like what we have, the vision centers, though they are at the bottom of the healthcare pyramid, I think they would be the enablers of the care happening at tertiary level, which most often tends to be chronic. And because you're closer to the ground, because chronic care requires compliance, repeated visits, follow-up, the supply chain, and so many challenges, which tertiary care is absolutely not in a position to kind of fill. So I just want to kind of run through a few slides of a case study from one of our smaller hospitals, which has got 7 vision centers. It has a population of 1.2 million. Now we have 7 primary eye care centers, a base hospital, a doctor-run clinic, about 9 facilities, all strategically located. The areas where you don't find anything are basically forests and hills. So in this area, no one really needs to travel more than 5 or 6 kilometers to access eye care. As a result, pretty much everyone who needs eye care gets it, and more importantly, they're able to get it in a very timely fashion. And then these centers, which are very low investment, constitute to more than a third of the work done in that whole district. So the last mile coverage, I think, in addition to giving that access, is also a very significant intervention. And then we also did the math around finances, which is very critical because for scalability, it also has to be financially viable. So these centers are operationally cost neutral. They don't make money, but then we don't lose money either. But then you're also able to save a lot of costs that you would otherwise incur in outreach. And then there is some additional income because not everyone in the rural area is poor. Those who have the wherewithal pay for the services that can result in additional income. And then having recognized the power of these centers, we felt that we need to propagate this widely. So we have been working with many state governments, helping them pilot this. Tripura government has covered the whole state. Tamil Nadu government is the most recent, where they piloted 1 center in each of their districts. Bangladesh, they are fully signed on. They will have 200 centers very soon. The Prime Minister committed that the entire country would be covered through maybe 400 or 500 such vision centers. And we are hoping over time, whether this can provide access to close to a billion people or 100 crore people. So in conclusion, I think what makes this happen is fundamentally the mindset of the providers or the leadership of wanting to provide eye care to everyone. I think the co-speakers, Sujay and Radhika, are examples of that mindset. And then they have to make last mile care integral to the whole healthcare system. Only then it works. That integration is very critical. And you have to have a very proactive thinking and design, both for accessing and for completing the care loop. And towards that, I think we as providers have to constantly challenge our team to be able to do this, because this work is not easy. This is got a lot of challenges. So we have to constantly encourage our team to work towards this. So I will stop sharing and then maybe Subhajit, back to you.
Yeah, thank you, sir. So it was really, we all are inspired. Okay, so Radhika, how you see the rural healthcare system, because you, I think you are practicing in Delhi, and do you find it different, like from urban area to rural area, because you have worked, since you are working for rural area from since last few years. So could you like tell us more about what kind of challenges you faced or what kind of barriers you tackled?
So I think am I audible?
Yeah, you are not.
Yeah. So I think it was very apt, and the Aravind Eye Care model has really been a very big inspiration for me when I was reading about non-profits. So thank you for telling me a lot about that, sir. And what I feel is the major problem, as the other two panelists have also elaborated, that in the rural healthcare space, one, of course, the accessibility is a problem when it comes to both geographical access, and there are socio-cultural barriers, specifically when you go into tribal belts, where they don't accept any kind of help from outside. And that I think has been a very big issue in reaching out to them on how to, any kind of intervention, if you suggest, they're not very amenable to it. And as rightly pointed out by Sujay sir, the best way to deal with this problem is to empower and train community health workers from within the area. So I think this was one of the major challenges. And aside from that, I think a very big challenge is lack of awareness. So you can only give a person help if they are aware that they need help. Now, what happens particularly in pediatrics is that the child will come to the hospital or seek medical attention only when the case is too far along gone. And, like if you take a history and you see a baby who's got massive respiratory distress, florid pneumonia, the respiratory rate is 70 or 80 per minute, and you'll ask for how long has the baby been like this, and they'll say probably a week or so. So by then, the pneumonia is so far along that you will need a ventilator, and you might not even be able to save the baby even then. And same with the neonatal sepsis or any kind of infectious disease or just any, problem. It usually comes and manifests, and they seek care only when it's too far along gone. Same way as sir was saying that, only 7% of people were turning up for those camps, because what was the limiting factor here is that they don't know when they need help. So I think that is a very big barrier, and that is the only way we can actually tackle that problem is by raising awareness, or alternatively sending health workers door to door to screen these people for a set of problems. Now again, the scope of a community health worker is very limited. How much can you train them, and how much can you how much can you teach them? They are going to be semi-literate or moderately educated people. You cannot, the kind of doctor-patient ratio that we have in the country, we cannot send doctors into every single village and tribe. It's absolutely impossible, and that I think is also another major barrier when it comes to care in these areas. So I think for me, these are the major three barriers that we have encountered, and we're trying to tackle them in the best way possible. But there's still miles to go, and I hope that in the future with the two apps that we're developing. So we're developing these two apps. One is doing e-triage in the field for children specifically. We're training community health workers to pick up danger signs in children and reduce that time with when they come to the hospital, between falling ill and coming to the hospital, to reduce that time. And the second is to detect severe acute malnutrition by health workers. Again, to prevent devastating, disabling consequences of malnutrition like preventable blindness. So I hope that we can tackle this problem.
Yeah. Okay, Radhika. Sujay, I would like to ask you one thing. India has three-tier healthcare system. If we talk about rural India, and there are several missions like Rural Health Mission, and there are several things. Then why there is if we talk about the network, there are I think 155,000 sub centers in India, more than 25,000 primary health centers, and 5,500 community health centers. But still, why private players or NGOs or CSRs are needed in this sector?
Yeah, that's a very good question. Our objective is that we want to scale in three ways. Own model, which is our own clinics. We have 10 of our own, and we want to scale to 200. Why 200 and why not 2,000 or 200,000 is because we want to work in partnership with corporates and multilateral agencies along with government. So in our operate model, we are working with the corporates like the Jubilant Bharatiya Group across 6 cities in India and many others. As well as in the enable model, we are working with multilateral agencies like JICA, Japan Industrial Corporation Agency. When we started the work with JICA in Jharkhand to upgrade 12 primary healthcare centers as the health and wellness centers, our objective was that how is it really possible to identify, for example, in some of these primary healthcare centers, they were on lock and key for last 2 years, 3 years. But when we opened that and we enabled that to upgrade that as a telehealth facility, there was a lot of insights which came out. Some of the insights are we have the Ayushman Bharat platform, which is there to provide telemedicine. Now, what we have figured it out that let's say if there is a doctor who is sitting in Ranchi who is willing to provide telemedicine, and the doctor is available morning 9 a.m. to 12 noon or 9 a.m. to 1 p.m. This doctor is speaking and conversing in Hindi. If a patient who is in Torpa who speaks in Mundari language, how do you think the communication is going to happen? Of course, the patient does not understand the doctor does not understand the patient. This is not going to work. Similarly, in many cases, the community is not mobilized or they really don't know that these kind of services are there. They might feel that, okay, I am going to the doctor, but maybe I'm not getting medicines and these kind. So iKURE came in to enable and work with the government to, so that we are able to leverage the existing infrastructure of the government, the existing doctors, plus iKURE's doctors are given when beyond these, government doctors time. For example, if somebody is having any problems, of course, they will not wait and they have a problem in the afternoon, they will not wait for the next day. They would want to get treated at the earliest. So in this case, we have increased the span of time. We have increased the available dialects of the doctors so that the patients and then the community health worker, when they are coming in, they are able to translate the conversation between the patient and the doctor. They are able to measure the vitals and then the telemedicine happen. So these kind of innovations which we have done, and some of the initial success stories has been phenomenal. We have the 2 clinics which were absolutely a lock and key. We have seen more than 1,000 patients in a single week in these 2 clinics. So you could understand that problems are there, infrastructures are there, facilities are there, but maybe some tweakings that can really make it work. That is where we have to come into the things that, okay, if you're able to do those tweakings to understand that we have written to the district collector. District collector of Khuti is so happy and elated. He has appreciated our work in his official Twitter handle that how we have been able to transform the things. In 2020 and 2021, Nagaland, again, it's an extremely remote state, hilly terrain. We partnered with the government of Nagaland to roll out that aided telemedicine across 193 primary healthcare centers and sub-centers by leveraging the existing government network and the community health workers. So what I'm trying to say here is that we have seen the example of vaccination drive. Vaccination drive, how do you think it has been successful? It has been successful because of the joint participation between the government and the private. Do you think any one single entity would have been able to make it successful? I don't think so. So in India, we have demonstrated some of those initiatives, which is a joint drive between the public and the private together to make it happen. And each of them knows their roles very, very clearly. In our case, what we say is that we are really good in implementing and execution the things and also having a robust technology that can integrate. So if we are able to leverage the existing government infrastructure, the existing government resources, and bring our know-how, our disruptive way of thinking. So government is a large body, it's like a ship, but for startups like iKURE, we are able to bring a lot of disruptive innovations which can make it tweakings, and then that's how it can be successful. So this is how we have been doing. We have also started another work with Mug for Mothers for providing precision health for the pregnant mothers in Jharkhand. And here also we have seen that many of the pregnancies are detected at the 4th month, at the 5th month. So if a pregnancy is detected, I mean, of course, they're too shy, so they will not tell outside that. And then there are, community related challenges. They see ki theek hai, nazar lag jayega, and all that is there. So how do you handle with, how do you give confidence to the communities ki theek hai? It is very, very important that the moment they know that they are pregnant, how they can, register themselves so that they are able to get the government benefits. Government benefits are there. Government benefits are there, but that is not reaching each and every citizen. That is the biggest challenge. So how you can really communicate to them, tell them, give them the confidence, and then integrate them as part of that methodology. And in many cases, we have also created what we call is a combination of the government services as well as iKURE services. For example, government has some entitlements to provide some of the basic services. But on top of that, if a patient, let's say some surgeries or some tests, the patient has to wait for 1 week, 10 days. But if we are able to, in case of vaccines also, we have seen that we have both the models, the free vaccinations as well as the paid vaccinations. So whoever wants to use the free, they can wait and they can avail. However, who can have the ability to pay, they are able to do that. In this case, also in healthcare, also if you have those combinations, that if you are able to integrate both the free and the paid model under one basket, you can increase the basket of services manifold. So we are actually exploring some of the models, which is called the integrated dashboard. In partnership with UNDP, we have been discussing on. The objective of UNDP, the integrated dashboard is, imagine if a patient or a pregnant mother is trying to get some of the tests, only 20% of the tests could be availed by a government facility. 80% of the tests, they have to do it up from outside. So when they are going out to do those tests, they are leaving that system. And then it is becoming extremely difficult for the doctors to manage, monitor, and track those patients. So as part of the integrated dashboard, the way it would happen is that you would be able to integrate everything so that the journey of a patient is able to be tracked and monitored. You see the example of COVID portal. I have taken my first vaccination in a government facility, in a PHC. My second vaccination was in a private hospital. But in my COVID portal, I can see that I have taken all the vaccinations. That is how we can really achieve. So when we have that flexibility, when we have that integration in place, when we are able to optimize whatever infrastructures or the resources are there, we can definitely break such barriers and make it successful.
Okay, great. So, Mr. Thulasiraj, would you like to add some point? Like, if we talk about especially eye care, where do you find like government healthcare system is where? Yeah.
So I think we need to understand India a little better from a healthcare point of view. So the question that you asked, since government is omnipresent in the entire country, why do we need other players? But then India is not set up to provide all care to everyone by design. No, it is not like the UK NHS, where the government has said, as a country, we will take care of the entire healthcare, and they set up systematically the infrastructure. There is a GP for every 3,000 population. Now we barely have an ASHA worker for every 1,500 people. So it's a very different kind of a commitment that the government has to make. And I don't think Indian government now has the wherewithal, where they're spending a couple of percentages of the GDP for healthcare. I don't think they will have the wherewithal to provide the care by themselves. So India, by design, requires multiple players to come in. That's how the landscape is. And there are many other countries like this. US. There are a few countries like UK, Canada, so that's a fundamental difference. So I think by design, all of us have to contribute. That is one part of it. And then kind of a related response to you. This primary eye care, which is the topic of the session today, is the last mile. I think it is still evolving, even conceptual. If you look at it, the primary healthcare for most part was synonymous only with diarrhea, cold, cough, fevers, and maternal services. It was as if like all of the specialty care, there is no primary element to it. Only recently they've added NCDs. Things like hypertension, diabetes, stroke, they have come in very recently. So if you take all the other subspecialties, there is no primary care component now. We are introducing, for eye care, we're introducing, I think it will catch up very quickly. And we're also having the primary health centers to establish this component within their service. So I think there are multiple reasons why other players have to come in, from filling the capacity gap, which is not designed to be universally government, helping the government to augment the scope of the last mile coverage. I think there's got to be an element of oncology in primary care. There's got to be an element of cardiology in primary care. I think whether it is case detection, prevention, or whatever it is, that's got to be there. And like Sujay said, I think innovations are, I think, little more likely to happen, in organizations that are newer, smaller, younger, And I think that's again a major contribution that we can make to healthcare in general. Yeah.
Okay. So, Radhika, would you like to add some points? Your view? Yeah.
I think what both of sirs have said is very, very apt, and there's not much left to add. But I'd just like to, say that I think it's unreal for a country with with the expansive population, explosive kind of population that we have. I think it's unreal for us to expect that the government will be able to, like Sir said, we need cardiology, we need oncology in the peripheries, in the tribals, we need everything everywhere. So that is where non-profits and other stakeholders can really jump in to bridge those gaps, and that's what we have been doing. So it's more of us working alongside the government and reinforcing what the government is already trying to do. So I think that is a very good strategy, because the government programs in all essence are good programs. It's just that they lack accessibility. So, like there are so many amazing foundations, like the Child Heart Foundation, which we work very closely with, and the founder is a pediatric cardiologist. So again, they follow a community health and telemedicine model, and they even provide funding for extremely high risk surgeries for children who need heart surgeries but cannot afford them, because in many it's very difficult for people to get those surgeries done pro bono even in government hospitals. So I think there's a lot to be done, and there's a lot that all of us can contribute towards, and I think we're all doing a great job of it so far, and there's lots to be done even now. So that's what I'd like to add. Yeah.
Okay. So, Mr. Sujay, like every quality service comes up with some cost. Yeah. So, do you find any scope for profit-making private healthcare players in rural market?
Yes, definitely. In fact, we have been profitable for last 3 years. So that means that if you are able to provide good quality services to the communities, definitely they would be willing to pay for such services. For example, imagine the kind of tests which we do. It could be for hemoglobin, it could be for ECG, it could be for other lipid profile and other blood tests. Our services are at least 20 to 30% cheaper than the market rates. Even in case of medicines, they have to buy medicines at an MRP from the pharmacy store the moment you move out of tier 1 cities. But in our case, we are able to pass on the discounts of more than 10% to these patients. So obviously, when they are getting such services at a good quality, they would be willing to pay. And even in case of spectacles and other products, so all what has to be very, very made out very clear that it is, I would say, improper to think that the rural patients or the rural communities do not have money. This is not the case anymore. We have in most of the locations, there are definitely populations which is absolutely poor, and that percentage could be maybe around 20-25%. But there are 70% of the patients or more who can pay on an average of 100 rupees, 150 rupees for a doctor consultation and medicines. So all we have to design and think that how you are able to provide the services, whether that is meaningful or not, whether they are able to add value to them, and you would be able to, like in our case, we work on a volume-based model, meaning that when we are able to provide the services, we would be doing that. Just to give a quick example of the recent activity which we did, we started our own healthcare intervention in Kumirmari Island. Kumirmari Island is in the the last tip of the Sundarbans, and after that we have the Raidigi River, and then we have the Bangladesh. And this island has seen tiger attacks almost every month because the tigers, they swim the river and they reach this island. 20,000 people stays in this island. Number of formal doctors is 0. In case they have to come to get to a doctor, they have to take a boat, which takes around 6 to 7 hours to reach the mainland. And from there, they have to take a Toto or any kind of van, which takes to the Canning location, which is the hospital, another 1 hour. So almost the entire day. And the boats are available only from morning 6 a.m. to 1 p.m. And that too when there are clear skies. Sundarbans as a geography has seen 4 cyclones in last 2 years. So when we started with our own healthcare intervention and we have deployed our own community health workers, the patients are elated that if they have to go and buy medicine, Gelosil as a medicine which is maybe less than 2 rupees, they have to pay 10 rupees to buy that medicine in Kumirmari because of the transport costs and the unavailability. So when we are able to provide all these services at a meaningful cost, the patients are paying for that. So all we have to do is that how you are able to design the services, whether they were saying that, okay, some of them were complaining that no, here NGOs comes every 2 months, every 3 months. That was the initial reaction which we got from the communities. I said, fine, when the NGOs are coming, they are mostly doing eye camps. They are not doing any other services. And you have to wait for, so imagine if you have got some stomach pain or any other problems, do you wait for next 2 months to see the doctor? Obviously not. Or then you have to hurriedly go to the canning, which takes the entire day or maybe 2 days just to see a normal GP. So in this case, we are able to provide the services. We are able to provide aided telemedicine, giving them medicines, immediately, and that is the value proposition which are able to provide to the communities. And in the last 1 week itself in Kumirmari, we have seen more than 200 patients. So you can imagine that it's only the demand and the supply gap, how you are able to design this. Don't you think the FMD, these villages are not buying Maggie, they're not buying Coca-Cola, they are not buying, they have AC beauty parlors. So if they are able to buy for other products, why not healthcare? So we have to really come out of that whole thing that rural patients means poor patients. I think that definition of India has gone. So definitely we have to think that if you have good quality services, definitely the patients will be buying. And for those patients who are not able to pay, we have the CSR programs to cover for that. So that is how I think we can design the systems in a way wherein it can cover the entire population in a very effective manner.
Okay, great. So it means a rural like healthcare market has potential to attract like healthcare players, private players. So Mr. Tulsiraj, would you like to add like
Yeah,
something? Yeah.
I think Sujay covered most of the points. I think what we have to recognize is that I'm just going to rephrase something that Sujay so eloquently mentioned. So as providers, one, like you said, rural does not mean poor. No, that I think we have to get out of our mind. No, I'm from a rural area. No, I'm reasonably well off. So rural is not equal to poor, nor is it equal to uneducated. No, so that is one. But I think rural people, because of their geographic location, have a lot of access disadvantage. So access also means cost. Like you said, if Jalus is not available in the island, to buy a strip of Jalus may cost a few hundred rupees. No, if they have to make the trip to the nearest town and buy it. No, so that is the disadvantage they have. So the providers have to have the mindset of how can I minimize effort and cost to the people, and they have the potential to do that. Now, because as a provider, you have certain scale to work with. No, but for an individual patient, the scale is one. No, so any effort is all attributed to that one individual's transaction, which is what makes it very expensive, and they don't do it quite often. No, so I think this is something that we as providers have to recognize. Okay. Which is why in our primary eye care and vision centers, we provide glasses right there. If you don't do that, let's say the glass costs about 400 or 500 rupees, and they're happy to pay it. But if you don't provide it right there, they would easily spend another 500 or 600 rupees just to get the glasses, and on top of that, pay for the glasses. Now, because they have to necessarily make a trip to a larger town, at least 2 trips have to be made. So I think a lot of the money or the financial viability of these kind of services can come purely through cost savings. Okay. And that's not trivial amount.
Okay. So, Radhika, like in last few years, there has been a revolutionary work in field of transport and digital connectivity. especially in rural areas. Do you think it will impact the healthcare system?
Yes, definitely, because like all of us have been specifying, accessibility is a huge problem. So, for instance, if you look at areas in the northeast, in Manipur, in the extremely rocky and mountainous areas, there it takes a lot of effort to reach those areas, specifically because they are so inaccessible, or they're surrounded by dense forests, or they're surrounded by, very hard to navigate through sort of geographies. So I think if transports and logistics have developed, and specifically now that we're seeing a lot of development in the sector of drones. So if all of these channels can be utilized to deliver life-saving equipment, or to help us overcome these accessibility issues, I think a lot of our problems will be solved when it comes to, and look at the amount of expense that goes in logistics. Because if I have to send, suppose a donor is sending me 20 oxygen concentrators for Manipur. The donor is going to send it from Delhi or from Gujarat, where they are manufactured. Now, to send it to Manipur, I have to spend at least 40, 50,000 just in logistics. So just imagine the kind, those 50,000 could have easily gone in saving so many lives, instead of being utilized in logistics. And even though we've tried everything, we've tried to reach out to logistic companies that we're doing it for a good cause, but it just doesn't work out like that. They have to see their own profitability and their own business as well. So we're not able to get logistical partners, and I hope Sujay sir and Tulsiraj sir, if you have any ideas on how we can overcome this problem, do let me know, because this is something I face on a daily basis. That logistics are proving to be extremely, extremely costly, specifically for heavyweight items like concentrators, or if you have to send something in bulk. Like in December, we were very overwhelmed with the sort of winter that we were having, so we wanted to send blankets, particularly to Northeast. Now, if I'm sending, 500 blankets to an area, how do I justify spending that much money on the cost of transportation? The blankets are manufactured in Panipat. If I try to purchase the blankets in the Northeast, it costs 500 per blanket. And if I try to purchase it from the manufacturers in Panipat, or in these areas where woolens are made, it's hardly 90 or 100 rupees. So I have to see where the donor's money is going also. And we have to see, ultimately it's all about helping people, as many people as we want. So we don't want so much money going in these things. So I think that's my take on how good accessibility could really help us when it comes to rural healthcare.
Sujay, would you like to add something?
Yeah, logistics are definitely a major challenge in the far-flung areas. And so, for example, we are actually working on a model on the supply chain challenges in the last mile, and how we can really deliver medicines and others. If I try to give a quick example, let's say of again the Kumir Mari, the Sonagaon, and the Choto Mulla Khali, these are all the islands in Sundarban. One way is when we are sending our team member to go to the islands to deliver. The other way, we have also figured it out when these health workers are also crossing those boats and coming to do that. So in that case, the boats for them takes only 20 rupees for one boat, and then they have to do 3-4 boats, so maybe around 300 rupees. And when we are setting up the hub, which is in the just in the port of entry itself, then they are able to carry out in the bulk and then distributing. So anything to do with in bulk. So in case of Northeast also, when if there is a container which is being booked, and when you are trying to ship that, so probably you would be able to bring down the cost. So we have to optimize wherever it is possible to work on that. And in our case, the supply chain framework that we have built in terms of the inventory, for example, when the medicines are being sold, when the spectacles are being given, they automatically, all the inventory could be managed and tracked in the phone itself. In case of medicines, they normally, what we have seen also is that any digital play store, they are delivering medicines, and I have got the medicines wherein they have delivered the medicines at my doorstep on the doormat. I mean, medicines is not selling onions and potatoes, right? We have to understand that. So medicines are also when you have to actually deliver medicines and explain it to the patient. Even we educated, we get confused ki ye prescription dawai kaise lena hai, I don't know. And when our health workers are going and delivering medicines, they are able to explain, and then that's how the whole meaningful conversation happens. So we have to figure, and so the delivery agency is going and giving it at a point, let's say a club or a facility, and from there the health worker is picking it up and then actually delivering at a patient's doorstep. So we have to work, and India, we like Jugaad innovation. So wherever we feel that key, how we can optimize the resources in whatever meaningful and possible way, we can definitely do that. Yeah.
Okay. Actually, few days back, I visited a very interior village of Bihar, Khagadia district, and it was flood-prone area. And I was shocked to see the transformation. Small kids were having Android phone in their hands, and I have seen Amazon delivery service over there. But at another part, when we see there is, if we see the healthcare system, there is lack of proper infrastructure, no building at all. There is no oxygen cylinders available in those areas, no ambulance service. Uh, like uh, there are no testing units over there. So, how you Tosiraj, could you see like in one direction we are developing, but if we talk about healthcare service, we are much lagging behind. How we can compensate it?
I think you're asking a very, very fundamental question. Why in some areas or in some industries things are better and not in other areas? I think one simple answer is leadership. I think if you go down to the root cause of what is making something succeed and what is making something fail, I think it will all point to the kind of leadership and the commitment that leadership exhibits. One kind of leadership will figure out how do we make it happen. Bezos of the world will think like that. Anything which is dysfunctional, they see it as an opportunity. But then unfortunately that kind is few. But most of the leadership, the way they look at a situation is they look for excuses to explain their non-performance. Things don't happen. They say, "Oh, I don't have this. The buses are not going there. People don't work," and so they will have enough and more reasons. All of them will sound very logical. But then things don't change. So I think the very fundamental thing is around leadership. I don't mean at the prime minister or the health minister level. I mean, the operational leadership which can really make things happen. At a district level, definitely the CMO or whoever is the head honcho can definitely improve things. And we would see it also in certain government hospitals, things would work much better than the others. So I think the fundamental reason is that I think unless we fix that, anything else would be like a band-aid. It would work for a little while, and then again it would go back to the normal standards, and that's what we have repeatedly seen in many settings. Yeah.
Okay. If we see the number of beds per 10,000 people in a state like Bihar, because I belong to Bihar, so there is a very low number, like 0.6 beds per 10,000 people. So it is very when I see the healthcare system, our government system, I am really sometimes I'm very upset. So on another hand, we see our country, you talked about leadership. Our leadership are regularly putting their effort. India is only country who has implemented CSR compulsory, made it compulsory for those who are those who are making profit more than 5 crores. They have to pay their 2% for reforms and in these sectors. So could you tell me CSR can play a vital role in quick infrastructure upgradation or not? Radhika, could you please answer? Can
So I
CSR
think,
be? Yeah.
yes. So definitely it can be. It's just that there has to be a proper ways and means to do it. What happens, and I'm going to speak very candidly here because this is something we have been trying to do with CSR funding, and that is systems upgradation and health system strengthening of public hospitals. It was a part of the COVID relief work that we did, that we want to upgrade the ICUs in the country, we want to increase the number of ventilators, and we want to increase the number of BiPAP machines and ICU beds. So how we did it was that we have a donor, we have donors who are ready to give CSR funds. But see, giving CSR funds to people who don't understand, what are the problems that the hospitals are facing is not going to be of any use. So what we did was we connected with the major COVID hospitals in the country, be it Sion, be it KEM, be it Safdarjung in Delhi. All of these, those, the ones with the biggest burden of the pandemic, and we try to understand their needs. The way to understand the needs is not by talking to the admin. The way to understand the needs is by talking to the on-ground frontliner staff, like the head of the COVID department or the head of the infectious disease department, and understand, what are their needs and how we can help them upgrade the infrastructure. So once we got a detailed plan of what they need, then we had to convert that into a sort of a business plan / pitch for the donor, because that is what corporates and donors understand. They don't understand medical jargon. We will have to explain it to them in a language, which it's suitable for them. So like we converted that into a sort of a utilization / business plan, explained where the funding will be used exactly. So there is a lot of, how should I say, a lot of work involved in this. Corporates can't just go up to Sion Hospital and say, okay, we are giving you 3 crores and you do what you want with it, because most of it is going to be siphoned away. So you have to have someone ready to do all of this paid work. And that is why I feel that corporates, despite all of their best intentions at heart, are not able to help as much as they potentially can. Because that's all said and done, they have huge amounts of CSR funding to give, but it's just about where it can be utilized and in what proper manner. I think that's my take on this issue.
Okay. So Sujay, would you like to add some?
I think Dr. Radhika has covered most of the things. Yeah.
Okay. So, Sujay, I would like to ask a very common, like when we talk about rural healthcare system, there is very common practice, the casual attitude. So we talk about system, but this time we are going to talk about the rural public. Actually, they are having very casual attitude towards any health problem. They are they always try to hide it. They prefer home remedies unless problem gets to next level. So how we you think we can bring change?
Yeah, I would say that the casual attitude. So maybe I'll not use the term casual, but maybe ignorance. It's about ignorance or not knowing that how grave that problem could be. Like when we started with DR, diabetic retinopathy, in 2 of our locations, Domjur in Howrah and Hoskote in Karnataka, we saw that especially in the semi-urban rural areas, they were really not knowing about this thing, that in case there are diabetic patients, this could be a problem, major problem. And similarly, in case of the pregnancies, when we connected with the different pregnant mothers and others, and telling them that, do you really know that vaccination in the first trimester is important? They said, we do. And also they said that they know many of the other things, but it could be also about the ignorance or not getting the right kind of access in the right point in time. We have to also understand it's not only about rural, even in the semi-urban or the peri-urban locations. What is the immediate problems that the community, it's the bhook, it's the hunger. They have to earn their own means to get themselves and their children and their families fed. That is the most immediate task. And in order to do that, what in many cases what happens is that if they have to go for health checkup and others, if they have to give their entire day to do that, that will lead to the loss of wages. So there it comes to theek hai, isko baad mein dekh lenge, because if I have to really do that, then I have to do away with my earnings for that particular day. So that is also, they have to do a trade-off in that case. But if you are able to provide the services close to the community, if you are able to educate them, make themselves aware, and we are seeing that there is an abundance of the willingness for the patients, and especially as Thulasiraj sir also mentioned about, the rural people are not uneducated anymore. We have most of the youngsters, they are going out in the cities, they are for studies, for work. When they are coming back to their hometowns and then in the places, they are again telling their parents, telling their seniors that, okay, this is right and this is not right. And that is how we are able to see a true transformation within the communities. So in a combination of the young educated class who are going back to the villages and telling their communities, telling their parents, then the kind of services which we are be able to do, the smartphone penetrations has really made everyone educated, what is right, what is wrong. Those kind of things are also happening. So the awareness level has definitely increased manifold in the last 10 years, which we have seen, and that is going to also increase further. And even if you see the level of superstitions and other things have also drastically come down over this last several years. And that is how I think we have to continue. For example, the usage of the sanitary pads within the communities was absolutely no, in several decades before. But now we have seen that there is a, welcome change in such things. So obviously you have to, it's not like, plug and play, ki aapne button dabaya and everything is happening. It does not happen that. You have to be continuously at it to make things work. And when that realization happens, then obviously you will see that change.
Great. So, Mr. Thulasiraj, would you like to add some?
I think Sujay covered with a lot of insight. I think fundamentally, I also believe that the people in the community is quite intelligent, and then they are capable of making the right decisions. But I think quite often we as providers are the ones who fail. I think the fundamental point that he made is, they do their own cost benefit analysis. Like the lady who came and bought the glasses in the video that I showed. She did that because it just took about 30-40 minutes for her to do that. She's a tailor. And so she could just leave and she's self-employed tailor. So if she doesn't work, she doesn't get money for that, and she gets probably brickbats from the customers for delayed delivery or whatever. But then half an hour she can always squeeze in. And if that service was not there, she would probably not get the glasses at all, or maybe till it's very late. So do we call it as ignorance or casual? I don't think so. I think we guys have failed in creating access and affordable care. So I think unless we really have to own that. I think one area where awareness may be required, and it's not only for rural, is an example that Sujay also gave about diabetic retinopathy. Like some disease conditions are not visible. You don't experience it till it is very late. Including cancer and many other conditions. I think it is in those areas wherein some awareness will be required, and that I think is required across the board. It is not rural or urban. Okay. And again, what happens beyond creating awareness is what we have to be thinking also. It is not just creating awareness that diabetes causes eye defects. Okay, I know that. So what do I do with it? If I can't do anything with it, that awareness effort is completely wasted. So we as providers have to be able to think sort of a little more comprehensively about closing the loop.
Okay, so Radhika, can I have quick view of yours on the same point?
As a doctor, I feel that there are two ends of the spectrum when it comes to patients, both in rural and urban. And this is more, if you're talking about casual attitude, it's not just about rural people. There are also patients from extremely well-off backgrounds in urban cities who will come and say, "Oh ji, 600 की sugar चल रही है, एक हफ्ता हो गया और हम तो रामदेव का इलाज चला रहे हैं." So it's the attitude is not, it's not a thing limited to rural. And at the same time, there are also patients, who will call up that, my child just hiccuped. And they call up in franticness even at the smallest of things. So there are two ends of the spectrum when we talk about clinical practice. And I think having a balanced approach to health is what is lacking in most of the healthcare systems across the country, in most of the healthcare attitudes of people across the country, that they don't have a very balanced approach. Either they will be extremely, health obsessive, they'll go for fat diets and they'll go to the gym, or they'll be extremely callous and say, the health is not my priority. So have a balanced approach if someone could just have some sort of awareness program on how to balance your health life is also, I think, it's going to be a good startup idea.
Okay, since we are almost out of time, so in 30 seconds, what is the main message that you would like audience, or you can say future social entrepreneurs, to take away? The conclusive line. Mr. Sujay.
I think you have to be on the wicket. There would be bouncers, there would be many challenges, but you have to stay on the wicket. Social entrepreneurship is a long haul. It does not give you immediate results. You have to deal with multiple challenges to make convincing stories for the people to adopt, learn, and things like that. So that's the perseverance is definitely key to success. And one important also, we are also setting up a living lab in Baripur, which is a congregation of that how we can bring world-class researchers and practitioners. So I would like to welcome XRI students to participate in that. We'll have phenomenal research that we have already University of Michigan, McGill, and several universities on board on that. So I would look to welcome you all as part of this research facility, which can bring a good change within the communities. That matters the most. Thank you.
Yes, sir.
Yeah, I mean, going back to the topic of this session, the last mile coverage, I think it's a very exciting field. I think in India, the opportunity today is enormous. I think the digital connectivity and then some of the other enabling things like Ayushman Bharat and which takes away the financial and things like that. It is sort of a very opportune moment for budding entrepreneurs to kind of explore that field, because it's a very, very open field, lots of possibilities and scope. And I think the success will depend to a large extent, thinking out of the box and figuring out solutions that can work in relatively smaller scale. Because as you go down to the last mile, the scale also drops. Making things cost effective and having them work at that level. I think it's an exciting field. It can be done. It is got to be done. Thank you.
Dr. Radhika.
Yeah, so for all budding social entrepreneurs, I think I would just like to say that this is your time and this is your country, this is your planet. Nobody from the outside is going to come and help you fix things here. So just, whatever skill set you have, you don't have to be a doctor, you don't have to be into tech, but whatever skill set you have can be utilized into doing good for the world. And I think if you are really driven, just channelize your skills into helping others as much as possible, specifically in a setting of a global crisis like we are in one today. So do your bit, and trust me, it has more than one sort of return to it.
Okay. Thank you. So once again, I want to state that we are almost grateful to all speakers on the panel. We thank you for being with us this morning. It's been great pleasure. We all are inspired by your great words. Thank you very much. Now we'll Sanjay will continue with question answer session. Thank you so much, guys.
Yes, thank you so much. It was an enlightening discussion here, and we'd like to open the floor for questions now. So among the participants, if you have any questions, you can simply raise your hand, or you can put it in the chat to any of the hosts or co-hosts, and we'll take it up from. The first question that we have received in the chat is, we have all spoken about the importance of technology in the last mile delivery. However, many communities do not have access to networks, and many of them are not comfortable with using technology. Like Anganwadi centers still now rely on registers, for example, for recording data. So how do we actually deal with these problems on the ground?
So I can take it up. So if I give the example of Jharkhand here, the ASHAs and the ANMs are using that, and we have the community health mobilizers who are carrying smartphones. Initially, there would be challenges, of course, but over a period of time, when we are able to show them the benefit, that how this can really help them. We have seen that many of them, even they are using technology in the name of WhatsApp. कि नहीं, WhatsApp से तो I can communicate with all the patients. Then we figure it out how many contacts that you can store in WhatsApp, maybe 100, maybe 1,000. But when we have beyond 1,000, how would you? So of course you have to use the proper technology as a platform to provide the services. So right kind of training, motivation, guidance, and the ability to convince them that this is going to make your job easier, not harder. That is like one quick example is when we started, we did the 3 research on capturing of 50 kinds of data on paper, tablet versus phone. Initially, the data captured on the paper was the fastest. After a period of 6 months, the data captured on phone was the fastest. So over a period of time, if you are at it, definitely you will be successful. Yeah.
Thulasiraj sir, do you have anything to add to this?
Yeah, on the technology front, I think the writing is very clear because things like connectivity, broadband, it is going to become much more universal. So the challenge is figuring out technologies that would actually address use case challenge or make things better for the field workers or for the patients. So I think even for entrepreneurs who are trying to enter this area, what I've seen quite often is people innovate a solution and then start looking for the problem. Sometimes it works, but I think quite often they're not. That doesn't really work. So, but then out there are plenty of challenges that need to be sorted out. And trying to get a deeper understanding of a use case scenario and then figuring out how technologies can be harnessed to address that. And then I think if you have built a solution around that, then you can make it work. Like for example, when we first introduced electronic medical record in the cloud, long before the language was there. This was in 2004, when there was no broadband connectivity, where we had to establish it ourselves. We were worried if the patients would be willing to talk to a screen, looking to a virtual doctor. But then what we realized was that really wasn't an issue at all. I mean, the patient for the very first time sitting in front of the computer screen was quite at home interacting with the. So that was, there are a lot of surprises. But then we solved the problem. So I think that's how it got a lot of traction. So to me, that would be the advice or a response to that.
Thank you, sir. I'd also like to ask Radhika ma'am, but I believe she's having some internet issues. So I'm going to take up a follow-up question which came up. Meanwhile, Divakar, I see you have your hand raised. If you want, you can go ahead with the question right now.
Thank you very much. Thank you, Thulasiraj sir, Sujay sir, for the fantastic work that you people are doing. Sir, I'm a research scholar interested in social health. I mean, social enterprises working in healthcare sector. So whenever we talk about social enterprises working in healthcare, Aravind is the the name which pops very first in our eyes. I just want to know, sir, how accessible Aravind and iKURE. I have got assurance from Sujay sir that researchers are most welcome. So I just want to understand from both of you how accessible these organizations are for research scholars. Someone who is, interested in the healthcare sector to explore it further.
Divakar, I'm not sure I understood your question. How accessible is what?
Sir, accessible in the sense, suppose I want to research Aravind from a different point of view. Is it possible?
The answer is definitely yes. Definitely yes. Now we've had multiple PhDs stemming out of Aravind. In fact, there are a few internal PhDs also working on it. So the answer is definitely yes. Yeah. But of course, we need to find the right fit, the devil is in the details. But in principle, yes. Yeah.
Thank you very much, sir. From Sujay sir also, actually, you
Yes,
mentioned
yes,
just now.
absolutely.
Thank you very much. Thanks.
I don't know if Maya is
Yes.
talking. Her mic is muted.
Yeah.
Can I ask a question?
Yes, ma'am. Please go ahead.
Hi, I'm Dr. Maya Mascarenas, and I have worked on both sides of the coin in the sense with Myrada, a huge NGO working in the field and community-based health programs. And now with NHSRC, which is focusing on rolling out the Ayushman Bharat. So my question, I'd actually put it on chat is, I mean, there's a lot of hope now with Ayushman Bharat trying to roll out a comprehensive primary health care and, also recognizing the importance of public-private partnerships, which both of y'all very, very well, explain very well. My question is, have we forgotten the role of the people in the community, because the last mile is with them. So what is the role of CBOs, the SHG, the VHSNCs that are there day in and day out? They just get a very perfunctory mention, but actually they really can play quite a role from my experience. So what is your view on this?
I think that's a very insightful question. So the way we kind of decode that is, if you take healthcare, I think to me there are two aspects to it. Now, one aspect is sort of a reactive delivery of healthcare, in the sense a patient with a problem or a need approaches the healthcare system. Are they able to get it? And quality, access, cost, all of that. That's one aspect of it. I think there we have to figure out what works. And there, the role of the community in the broader sense may be quite minimal, because it's individual, it's very transactional. But then on the other hand, if the goal is universal, everyone gets it, everyone need of it gets it. Okay? So when we take that kind of a proactive approach, there is no way one can do it without community involvement. I mean, that is where the CBOs and others come in, and we rely a lot on the community. So when so for treating patients in the hospital, we don't really need community involvement. But when you want to provide care in the community, make sure that everyone with whatever problem, is accessing it. Without working through community, we can't do it. So I think that to me is a nuanced difference between the two. I don't know, Sujay, I don't know what's your experience.
No, absolutely. I completely agree on that. In our case also, apart from our own community health workers, we work very, very closely with the self-help group members, because that is where, and in most cases, we do a bottom-up design, meaning that it's not that whatever services we have, we try to fit in. We first understand what kind of challenges that they have. We do a thorough need assessment in partnership with these self-help group members, trying to figure out. Till date, we are working with more than 5,500 plus self-help group members across different geographies. And we believe that their knowledge, their insights, their ability to understand the different problems, they understand the nerve of the people. And that's how we are able to design and deploy the services in partnership with them. So their contribution to the things is definitely very, very important.
Yeah, thanks. Because often we make the mistake of just treating them as beneficiaries, so they should go much beyond that. And when we talk about, attitudes not being there, awareness not being there, perhaps these can play a major role in that. Thank you so much. It was a very, very interesting panel.
Thank you, ma'am. We had a follow-up question in the chat. It's true that smartphone penetration is important for community awareness, especially through social media platforms nowadays. However, these platforms also bring a lot of misinformation that shapes opinions from the community members itself. So And this was pretty evident even during COVID times. So how do we tackle this kind of spread of misinformation, especially in this time of, the technology, viral technology that's available?
Yeah, so we have really focused a lot on the IEC materials through the posters, banners, different kind of videos which we have done. During this COVID period, we have seen there was so much of myths and the rumors which were plaguing our society and the communities, especially in the semi-urban rural areas. And most of the community members of the patients were absolutely confused that which is the right information and wrong information. So the right kind of messaging and in a very well-defined way and telling them about the different myths and the challenges is very, very important. And we do it a 3-degree approach, meaning that 3-dimensional, like if there is nutrition related things, we know that the pregnant mothers don't take decisions by themselves. They depend on their family members, husband or mother-in-law, father-in-law. So how we can educate the communities about different things. We engage the sarpanch or the village stakeholders. We engage the CMOH or the BMOH within that community and understanding what kind of challenges that they have. Apart from that, we also take a lot of insights from the self-help group members as well. And through those conversations, we are able to talk about, like we have talked extensively about mental health challenges during the COVID period, right kind of COVID treatment protocols, vaccination hesitancy, and many other things through the right kind of messaging at the different levels. And that has, been successful to, eradicate some many rumors.
Tulsiraj sir, do you have anything to add on this?
Yeah, I think misinformation is a much bigger problem. I think it goes beyond healthcare as well, and it is something which everyone is trying to kind of deal with. So I think the only solution is as providers we do what is right in terms of providing the right messaging out there. Now, because it's not. You are kind of against billions of users. Everyone has got freedom to post whatever they want. So there is no way you can control misinformation. Quite often it is out of ignorance. Quite often it could also be premeditated with some agenda. So it's very difficult to find a simple solution to it. But then to the extent that you can build credibility and people would check with quite often we get patients coming for a second opinion. It's very similar to that. So that's I think that's where we have to approach that. But we also have to recognize this whole social enterprise thing for last mile. There's a lot beyond just smartphone and technology. So we don't have to get totally fixated on internet and smartphone coverage to find solutions. Yeah.
Right. Thank you, sir. I just have to make a quick announcement before we resume with the questions. Radhika ma'am had to drop off because of some emergency. So she's not on the call right now. I just wanted to inform all the panelists and the participants of the same. We have one more question in the chat that says, how do we ensure last mile delivery for migrant workers and their families who lack documentation and often face problems due to continuous mobility, and they face challenges when trying to get covered by government schemes?
I guess with the government schemes, I think there are moves to kind of make it portable. In the sense, whatever benefits they are eligible for can happen across geographies. That may be there may be a lot of work that needs to be done, because
I believe we are facing a bit of an internet issue on our panelists' end. So let's just wait for 2 minutes while they try to reconnect, and we'll just resume from there.
Yeah, I'm back. Can you see me, hear me?
Yes, sir, we can hear you now.
Okay. Yeah. I don't know what happened. Suddenly I got bumped off and it reconnected. And I was saying with on the financial front, like the ensure Ayushman Bharat schemes, I think will be nationally portable. I think that's the intention. But then to make it happen, there will be a lot of bureaucratic wrangles that the states have to go through. So that's one part of the challenge for migrant workers. Other aspect is if the providers, at every contact that they would have with a migrant worker, could take an extra effort, to they can get a similar kind of a service if they're going to be going elsewhere. We would often do that to a patient who requires follow-up.
I believe Thulasiraj sir is still facing an internet issue. Sujay sir, actually, I'll just repeat the question for you. So what we were talking about is that how do we ensure last mile delivery for migrant workers and their families, especially when they do not get covered under most of the government schemes because of their mobility, lack of documentation and all?
How do we handle the healthcare of the migrant workers? We have been working with almost 40 odd real estate developers, and the construction workers are migrant workers, so they come to the cities. And in this case, the cost of the treatment and all is covered by these real estate developers. And so if they are coming to the city, definitely they would be working or engaged somewhere. So the owners would be should be on the organizations who are getting the work from them. However, when they're going back to their villages, what can be done is through the, because in the normal checkups they don't ask for any documentations, but if there are any additional treatment that are required, then they will be asking for the Aadhaar and those IDs. Probably there should be also a time wherein how we can, this creation of the Aadhaar and unique IDs is also a major problem for many of the vulnerable communities which is there. So we have to think of other ways of tracking and monitoring such communities who have been left out of the system.
Thank you, sir. Thulasiraj sir, you were talking when you got dropped off. So would you like to complete what you were saying?
I'm not sure where I left off. I think as providers, I think we can do something to provide that continuity of care, by advising them when they move to another geography where they can get, if some follow-up is required, taking that extra, because very often the providers are very transactional, but they would treat, prescribe. But then if you can take that little more effort to say that, because many of the conditions require follow-up or multiple visits, just checking on that and making sure that they're able to do it, would be one way of addressing that. Yeah.
Thank you, sir. We have just one last question, and this is from one of the students here, one of the HR students here. And so one of the primary challenges in the last mile delivery is the availability of providers at that end. So a question we have is that as students, as HR students, we recognize the disparity in the supply and demand of doctors or providers in the country, especially at the last mile, at the rural areas, and how it poses a challenge, especially for a country like ours. So how do we motivate doctors to take up practice in remote areas?
So the real challenge is that may be a losing battle if you just take that as a primary goal. Because all of them also want a life. They are married, they want their kids to go to school. Those are all real issues. So today we have many options to do this. Like the work that Sujay is doing, that we are doing in iKURE. Not every condition requires the expertise of a highly qualified doctor. Today with electronic medical records in the cloud, telemedicine, and then a person who is not a doctor but very well trained to do all the diagnostics and record them can be a very good substitute. Now, because if 100 people come in our experience, 85 people we can resolve completely the problem locally. Now, from investigations, diagnosis to prescription to them getting the intervention. Only 15% have to be referred to the base hospital for whatever. No, so that can be one approach that we can take to do this. No, it again depends upon the specialty of work. You know, like if you're a specialist, you require a certain population base for you to be effective and productive. Now, if it is primary care, probably a population of 7 to 10,000 may be enough, and then at some point can become attractive for doctors to go there and provide. Now, but then the local infrastructure will always be a reality that we'll have to contend with. Sujay, you have more experience dealing with this.
No, I agree with Thulasiraj sir. I think rightly said that we have to go beyond expecting that the doctors would be there in every village. That is not going to be there in the next 50 or 100 years. The only way is how we can empower, enable the frontline community health workers. So there is a basket of we work with more than 20 plus devices and we can carry out more than 100 plus tests at a patient's doorstep. So a combination of the frontline health workers, devices, technology, and the doctors who can be visiting maybe once in every week or once every fortnight can solve a lot of problems. And then if they need advanced care, they can be treated at a nearby hospital. So this is how I think if you are able to, because for the 90% of the care within the healthcare needs primary care. So if you are able to cater to that in a very meaningful fashion, I think we have covered a lot. And then anything to do with advanced care can be referred to the hospitals for further treatment.
Thank you, Mr. Sujay. Thank you, Mr. Thulasiraj. The topic of this panel discussion was bridging the last mile in rural healthcare. And we had a great discussion with the panelists who, with their vast experiences and bold journeys, took us into the realities of healthcare systems in rural India. I would like to wholeheartedly thank Mr. Sujay, Mr. Thulasiraj, and Dr. Radhika for taking out their precious and valuable time to share their knowledge and insights with us. It was indeed a privilege to have a sneak peek into your lives and to learn about the bold initiatives that each of you have taken. We thank you for your courage and perseverance and wish all of you all success in your future endeavors. Thank you so much. I also take this opportunity to thank Mr. Subrajit, who did a great job at moderating this panel discussion with great enthusiasm and energy. Thank you, sir. Now we will break for lunch. We shall be rejoining at 2:15 p.m. for the second panel discussion. I repeat, we shall be rejoining at 2:15 p.m. for the second panel discussion. Thank you.
Thank you. Thanks, everyone.
Thank you.
Thank you, sir. Thank you, sir.
Yeah. So basically, it's really strange that a country which is aiming for such high economic growth is so backward in very basic indicators of gender, nutrition, healthcare, and others. You'll be surprised to know that we continuously talk of, that we've increased our GDP, but we don't talk so much about the things we have not achieved, and nutrition is one such thing. And strangely, nutrition actually contributes, nutrition of communities and people. Strangely, community nutrition is actually what fuels the economic growth. So neglecting nutrition is really a very, very saddening and depressing state of affairs. However, I started very small. I think it's good to know from the young people here that I started when I was 23 years old. And I was armed with an MSc degree in nutrition. That's it. And I thought I'd sort of conquered the world and I knew everything. Till I really stepped into the real world of communities. I had never been to rural areas. And as soon as I went to the rural areas, I had to de-learn everything I had learned in my college. It is strange, but yes, I had learned about protein, calories, and how they affect everything. And when I went there, what I saw was poverty, lack of water, livelihoods problem, and all of these contributed to nutrition rather than, you know, the amount of proteins and what we continuously talk about. And one thing I want to clear from the start is that nutrition is not food alone. Nutrition word is nurturing. Actually, without nurturing, food does not get converted into nutrition. And that's something we all need to know. A child who's lovingly fed by any caretaker is more likely to grow better than a child who's just dumped some food, you know, or just given a plate. And that's what happens in rural areas. Even though there are a lot of food programs, the way these food programs are conducted often limits the nutrition acceleration in communities. And just to say this, that, you know, many children were getting food when through the supplementary nutrition programs, which I'd gone to evaluate when I started. But it was all being lost out in diarrhea because the water was so bad. So all those nutritional foods which were being fed and still being fed were being lost because the water content, water quality was not as good. So nutrition is not only giving food, but making sure that water is good, the quality of food given is good. Sometimes, you know, food that was given was just, you know, a packet of biscuits or something like that. Whereas there was so much good nutrition growing all around communities. So creation of CHETNA was the first step that I thought that we need to make communities aware of how nutrition can be done. But it was not only about communities becoming aware, it was also policy makers becoming aware, because they had designed these nutrition programs without really knowing what the conditions of communities were. So my sojourn in rural areas really taught me the real conditions of people. Supplementary food given is often fed to cattle, it's given to widows, and not really given to the child who really you know, deserves it or needs it. And my first surprise was when I asked a caretaker that who comes to the Anganwadi to take food. So they said a child who can walk in and take the food. And it was the under threes which were not coming to these supplementary food centers, ICDS centers. And that's when I realized that sometimes very good intention really does not turn out to become you know, a good reality in the field. And this is what I unlearned and learned both in the field level. And that's when I created CHETNA, which is Center for Health Education, Training and Nutrition Awareness. The nutrition was the focus, but we soon realized that, you know, if we don't have health as a combination, it's not going to work. Nutrition alone is not going to work. And a case in point is diarrhea, what I pointed out. So we are very, very focused on creating awareness, CHETNA, which is the word. And not only awareness among communities and disadvantaged and marginalized communities, but with policymakers on what policies need to be made. Because it was these policies which were badly designed policies which were affecting the community's intake of that nutrition also. So nutrition is key. Nutrition is key not only to health, it is key to economic, it is key to many other things which we are all talking about as a development paradigm. And if we don't have nutrition of communities, we are not going to have healthy communities. And we are not going to have the economic growth that we are striving for. So nutrition is key. And I don't know if you want to ask another question, but I can go off my journey or...
Oh, fabulous. Induji, because you have, this is 23 years MSc Nutrition, learning, unlearning, and you have discovered new pathways around. And I know from my personal experience the work that you have done and taught many people like us. I was just wondering, given the context now we have, in one study I was looking at, almost 70 to 80% of the food coming to the household is bought food. In that context, what role, and given that you have brought a center-staged community, and in some ways we have management graduates, the user terrain for any kind of intervention and insights around that is the most critical driver of a change process. So how would you relate with this, that poor people are buying a lot of food from outside? How does it impact nutrition? What can be done on issues of access, affordance, and things like that?
They say that the best food consumed is what is available within 100 kilometers of your village. Unfortunately, what has happened is that many of the foods which were grown earlier, like pulses and other products, they are slowly disappearing. Millets, pulses, all these healthy foods which were growing around communities are now being replaced by potatoes, cash crops like cotton, tobacco, and the like. So in this thing of producing, farmers producing a lot more from their fields, they have started growing that while livelihoods have improved. Unfortunately, the nutrition which was available to the families around communities has decreased. Earlier, we would have a lot of these foods. And in order to, for example, if I educate someone to have pulses, pulses are no longer available at a price that they can afford. If I talk of vegetables, many of the vegetables have disappeared from those fields. So agriculture policy is another very important part of this whole puzzle of nutrition. And when I talk of things what is available now, it's really very saddening to know that you go to a village, you can get Maggie at a food store or a Lifebuoy, which is very well marketed and distributed, but you cannot get nutritious food, or the food you get is packaged. You have these packaged foods, processed foods, which are easy to get. And that's what the mother gives to it's not that, she wants to give, but that's the very convenient food which is available, and it's available at a price which, they can afford. But if I tell her that, look, you have to make khichdi and you have to make palak and you have to make other things, firstly, she doesn't have the time, because unlike urban households, the woman is working the whole day, either in the farm or elsewhere. She cannot keep on making food. That convenience thing has happened. And therefore, often in the thing of creating more livelihoods, we take away from the household that person who's feeding the child. So, it's a very complex thing. Nutrition is not so simple as it seems. We were approached, for instance, by Sanand, the Tata Motors, and they had bought these lands and they felt that the nutritional status was going down. So now all the farmers had become rich because lands were purchased, but they had started buying these foods, packaged foods. Earlier, they would get foods around them. So it's not that was bad or this was bad. The problem is it's the whole, you have to see it in a comprehensive way. And that is often something not, can we give nutritious food in packages is one way. Can we have community kitchens which can feed, factories where community kitchens are there? Can we have, Supreme Court has passed an order that we have hot cooked meals. Unfortunately, that has been diverted, and people are pouring hot water in processed food, which is not even local. So, there are ways in which markets have taken over nutrition. And I'm not saying it is all bad, but what we say that, home cooked food, variety of food, nutritious food, biodiversity, that's disappearing from our markets. So, though our focus is education, but education is linked to livelihoods. And if livelihoods change or there is no livelihood, it will affect the nutrition.
Thank you very much, Induji. You have, the way you have described, there are no silver bullets around this. We'll have to have, there are too many intersections with the food system, with the livelihood, and the way we structure livelihoods with a demand and market-led perspective. It actually takes away food from the hands of the nurturer. And that is a very important and I must underline that without that nurturing, food does not bring nutrition. So thank you very much, Induji. And this is, I will come back to you in the next round. If I may request, Aparna, you have used technology so extensively, and we are familiar with your programs like Kilkari, and those are again, they have so much insights into the socio-behavioral aspects of adoption, and you work with the government in different parts of the country. If I would request you to share your perspective, and I understand you have a presentation. So if you can put on the presentation, that would be fabulous. You're mute.
Yeah, thank you for having me here. It's great to meet you, Dr. Manish. But I thought I'll put together a presentation on how ARMMAN approaches its work, right? One is to find problems, and another is to have an approach to it that works, and how I came about, building that approach, because I think this audience is full of management students. So I think it may be of some interest to them, right? So I'll talk about ARMMAN's approach to, what we saw. Is that okay?
Absolutely, that would be most apt.
Yeah, because Dr. Indu has, Ma'am Indu has given a real good understanding of the space. I thought I'll build on it and talk about ARMMAN's journey in it, right? Yeah. So ARMMAN's story. One second. One second. Can you? One second. I'm just.
If you can put it on full screen.
Yeah, I'm doing that. One second. Yeah. Can you see it?
Yeah.
Yeah. So let me start with where ARMMAN's story began, right? I am a urogynecologist, and I did my residency in Mumbai in Sion Hospital. And when you do residency in government hospitals like Sion, you see very closely how pervasive systemic problems leads to loss of lives of mothers and children that are completely preventable. And the basis for this loss of lives is often anemia in a mother. It's like a malnourished, adolescent girl becomes pregnant at a very young age, and she gets very little nutrition during her pregnancy. There is no iron supplementation that is adequate. She has severe anemia that becomes a basis for multiple conditions that lead to more preventable morbidity during delivery or mortality. When in the worst case, that leads to an underweight child being born, who then goes on to become malnourished, right? So I saw these cycle play out daily in my residency days, and one day, Rupa, arrived in labor, convulsing with severe hypertension, right? And she was severely anemic. And when I opened the records, I was stunned to see my own handwriting. She had come to visit Sion Hospital in 3rd month of pregnancy. But the overcrowded clinic meant that I did not have enough time for counseling on danger signs, why she needs to take iron supplementation, why she needs to seek regular care, right? We tell women to access care in the hospitals. Rupa had done that, but I failed her. And I saw these stories daily, systemic preventable problems resulting in women and children dying in the most unjust of circumstances, right? So, and if you look at the mortality in women, anemia underlies so much of that mortality, right? So in the next 1 hour, 3 women will die in childbirth somewhere in India, right? 2 children under age 5 die every minute in the country. If they not die, then almost, 45% of children in Mumbai are malnourished, right? If you look at urban poor children, they are 3.2 times more likely to die when compared with urban rich, in India. So these proportions are so huge only because of pervasive systemic problems, right? And two of the things I saw over and over again one was lack of access to preventive care information. If women are not aware about the care to be taken during pregnancy and infancy, they're not going to seek care in time. They're not going to take their malnourished child to the hospital. They're not going to access iron supplementation, right? And on the other hand, if we do not train our health workers to be able to pick up risk factors in time, it will be too delayed, right? The risk factors are picked up too late, and there's no closure of proof of care. And women and children end up in a dying state with late stage complications to government hospitals like Sion, where they're overloaded and there's increased maternal child mortality and morbidity, right? And so when I was seeing that in my residency days, mobile phone came to India. And within a couple of years, it spread through the country, right? And it became an important tool in my mind to be able to reach out with two things, right? On the one hand, we can provide preventive care information directly to women, without intermediaries, right? Without overcrowded clinics hampering the information we give them, or without, ASHA workers who don't have time to go and give the information, right? So why don't we reach out to women directly in their homes with information about the care to be taken during pregnancy and infancy, including maternal nutrition, including child nutrition. And on the other hand, train and support health workers for timely detection and management of high-risk conditions. And that's where ARMMAN came into being. And our whole hope is that over time, we want to reduce the number of late-stage and complicated high-risk referrals to almost 25% from the existing, 50%, so that there's overall reduction in mortality and morbidity. And we do that in a manner which is non-linear, right? What we do is that because we leverage technology, mHealth, mobile health, we are able to create scalable, cost-effective solutions, right? But we do not only use technology, we have a tech plus touch approach, right? So it's not just enough to send voice calls or enough to have training on phones for health workers. It's important to have touch points, right? But because we use technology, it enables us to keep the number of touch points required to the bare minimum, so that the solutions become cost effective and scalable and are easy to spread through the country. But we also design our programs using a community needs assessment approach, right? It's all evidence-based and down-up approach. And ARMMAN was founded in 2008. It was a very hard journey for 5 years where I couldn't get a single penny for our programs, because at that point in time, mHealth solutions were very difficult to, were new. And I was not from a technology field and did not have support, because all of these programs generally created by big multilateral agencies. But after a struggle of 5 years, ARMMAN started getting support, and now we are in 19 states and union territories, and our work has reached 27 million women and their children, and we've trained over 229,000 health workers over the last 7-8 years, right? And if you look at ARMMAN's journey, the first program we started off with was something called as mMitra, right? mMitra is a free voice call service, right? So what we do is we send preventive care information directly to the phones of the enrolled women in their chosen time slot and language, right? So we enroll women wherever we can get them, right? So women come for antenatal visit to government hospitals. We have a health worker stationed over time in almost 97 hospitals who enroll women in their first antenatal visit. But women come to the hospitals too late. So we also have partnership with community NGOs on the ground through whose health workers, we enroll women as soon as possible in pregnancy, because when they go on the field visit, they can enroll women in the field, and we financially incentivize them. So we've incentivized almost 7,500 health workers over time. mMitra has around 141 voice calls. It's twice a week in pregnancy and literally twice a week in infancy. So we handhold a mother through crucial, maternal nutrition points, through, iron supplementation, in addition to other aspects of maternal care. Same thing with the child, right? Breastfeeding, complementary feeding practices, right? All of that form a very important component of our infancy care messages, in addition to obviously other aspects of infancy care, because all works together, right? We have 3 tries for every message in the chosen, she's able to choose a time slot, right? So the woman, when we enroll her, can give time slot preference, language preference, and obviously the phone number. It can belong to her or the family. And then in the time slot that she's given, we have 3 tries for every message. If she's missed any of the 3 tries, we have a missed call system. she can give a missed call system will call her back. And we also have a call center, right? So she has any query, she can call back the call center and clarify those doubts. mMitra took off in 2013 and in a matter of years, reached almost 2.6 million women in 9 states. And because of the fact that mMitra did very well, we were approached with the government of India to manage a Kilkari program. Now, Kilkari is a program similar to mMitra. It's got around 72 messages. It's again once a week in pregnancy and once a week in infancy. It's also in 5 languages. And Kilkari, it has reached around 24.4 million women, right, in 17 states in union territories. And currently 1.5 million women are enrolled in Kilkari and 250,000 are enrolled in mMitra, right? So, our plan is to go through the country in the next 5 years. Now, on the one hand, we're informing women about the message, in care to be taken through mMitra and Kilkari. But on the other hand, it's very important to train health workers to be able to give that care early enough, right? So we have a mHealth-based solution for ASHA workers in collaboration with the government of India, again in 17 states and union territories. So there's a program called Mobile Academy. It's a voice call based refresher training program. It's got 4 hours of content. The ASHA workers call in and log off whenever they want to. And then there's a bookmarking system. And there are 11 chapters and 4 sections to each chapter. And there is a quiz at the end of each section. And that's how we kind of train the ASHA workers. Again, it's available in 4 languages. And the idea for us is that going forward, we now are going to go into Kilkari version 2, right? And Mobile Academy version 2. Both versions will have more multimedia approaches. Now, as we are expanding through the country, more and more women have access to smartphones, right? So what we're doing is to create a fit for purpose approach. That fit for purpose approach will be tailored towards the technology access that women have and the health workers have, also the risk factors they have, and the equity, problems that they face, right? So the idea is that if you have more high risk factors, we will handhold you more, right? We will have more two-way communication. You will have more, call center access. You will have more dedicated information based on that risk factor. The same thing with equity issues, right? So how do you reach a woman in the last mile, right? In parts of the country which are really underserved, tribal areas, areas with migrants, and how do you reach women from, Dalit communities or, Hindu Muslim community, all of whom are more encumbered than, women from, better served areas. So the idea is that the more risk factor you have, the more equity problems you have, the more we'll handhold you. So we're creating this fit for purpose pyramidal approach, where on the baseline, we will have the regular content, but on top of that, we are having more and more handholding, more two-way communication, and more multimedia access, right? Because now almost 50% of ASHA workers have access to smartphones, and they also access WhatsApp, right? Same thing with beneficiaries, right? So we're creating multimedia content, interactive quizzes, we're creating more simulations, so that all of that will lead to more two-way communication and more hand-holding of both the ASHA workers and the women in the field. Now, the idea going forward for us is that mMitra becomes a sandbox and Kilkari becomes our scale solution, right? So mMitra will test all new initiatives and they'll get scaled through Kilkari, right? That is two-way communication, multimedia, long-term hand-holding, all of that is getting tested currently in mMitra. We also have a long-term collaboration with Google on using AI. Right, so we deal with huge amounts of data, right? Almost 26 million women through the country, and so we have actually created, models which will help us predict which women are likely to drop out, which women are likely to not engage enough with the program. And using those AI models, we are hoping to increase the program efficiency and effectiveness over time, right? And on the health worker side, the first is the ASHA worker, right? The ASHA worker will go and, get the women to the nurse, right? That's her role in antenatal and infancy care. But, what we found was that the basic mortality happens at the level of high risk factors and high risk factor management by the, the higher levels of care, right? So you have the nurses, auxiliary nurse midwife, you have then you have the medical officer, and then you have the specialist. And in urban India, if you have a problem, you would go to an obstetrician who will manage you end to end, or a pediatrician. But in rural India, the issue is that each cadre does not really have an understanding of their part of the role. When are they supposed to refer to higher levels? what is the counseling to give, what to do when the patient comes back to them. And this problem I kind of broached with the Division of Maternal Health of Government of India in 2019, when we part of the committee recreating the antenatal care guidelines after 10 years. And they gave us a go ahead, and for 35 high risk conditions, ARMMAN had put together a team of doctors, and we created color coded algorithmic last detailed protocols, because those protocols do not exist at all, right, for high risk pregnancy management. So that, for every cadre, they have, properly laid out very simple guidelines on how to manage at their level each risk factor, right? And
Fabulous.
And then COVID struck, right? So then Telangana government accepted it. It's a model for the rest of the country, right? So the whole idea is that currently, as we speak in Telangana, it's called Amma Kosam program, just recently named, right? We've been doing it for the last 1 year, and it's the 5-year plan, right? So it is end to end, right? And nutrition is a huge part of it. So the way we're doing it is this, right? We've modified those protocols to Telangana. Then going forward, what we're doing is currently we are training, right? So you create a protocol that become policy. And now for 9,500 ANMs, 1,500 medical officers, and 350 specialists, we're actually conducting online and face-to-face training. Now, once we've trained them, we also want to handhold them, right? So all of them have access to a tablet, right? So all of this content is becoming part of a learning app, right? So there's a lot of multimedia content, two-way communication, live action, videos, simulations, etc., which is going to become part of that tablet, which will handhold them through notifications, etc. And then when they go into the field and implement those protocols, they should be able to come back and ask us questions. So there's a call center and WhatsApp support. So doctors who taught you will be available to answer all your questions. So then we have continuous hand-holding, because you can't just train them once. Then there's a tracking app, right? So all of the content is becoming a part of a decision support tool, right? So what's happening is that each state has a mother and child live database. Telangana has a really good one, called KCR portal. Now, what is going to happen is that as soon as the woman becomes pregnant, she gets input in the KCR portal, she gets linked onto the tracking app if she's picked up to have a risk factor. And we can track them end to end. The whole idea is over time, track every pregnant woman end to end to understand the health outcome of the mother and the child. And from that, we will know, we'll have dashboards at every level, so that we'll be able to understand where things are going wrong, right? So we can go back and do refresher training there, right? That's the whole idea. And going forward, Kilkari and Mobile Academy are going to Telangana next, right? Because we're in 17 states, next are the South states. And the idea is that we will link the backends of Kilkari, Mobile Academy, and the high-risk pregnancy management program. So what will happen is that eventually, if you find a part of Telangana is doing very badly in high-risk, in any high-risk condition, for example, anemia, through Kilkari, we can inform the women more. Through Mobile Academy, we can train the ASHA more. And through the integrated high-risk pregnancy management program, we can train the ANMs, medical office specialists more, so that we can have long-term hand-holding. And also we got AI integrated with this whole process, so that over time we're able to predict risk factors, right? So we are hoping that we're able to predict which child has malnutrition, which mother has, malnutrition, things like that, right? So we are able to kind of do more targeted programming, right? And another very important program from nutrition perspective that we have is one with UNICEF called SWABHIMAN 2.0. The thing is that when you talk about extremely equity encumbered areas, right? I'm talking about the border district of Nepal and Bihar, right? That Bihar district, and then Dantewada, Bastar, etc. The problem is that how do you reach the last mile there, right? And during COVID times, the Swabhiman program of UNICEF and the Rural Development Ministry, which works with self-help women's groups, were not able to really reach out to women. So we've added on, multimedia approaches or technology approaches. And so we're piloting in Chhattisgarh and Telangana. What we're doing is that we are collaborating with self-help women's groups, right? Because these are parts of the country where even ASHA workers are not able to reach easily. So what we're doing is that through the self-help women's group, these are women who are drawn from the community, right? We are increasing enrollment for Kilkari. We also have Maitri Kishori calls, right? So all the adolescent girls there will get information on health, nutrition, and mental health, right? And gender responsive key messages for adolescent girls. We also have Dr. Se Baatcheet, right? So, at-risk groups can access, government empaneled pediatricians and mental health professionals. And we have a mobile academy platform for the ASHA workers, we're going to have a similar platform for the chief resource persons of the self-help women's groups. Because currently, what has happened is that the National Rural Livelihoods Mission has added health, nutrition, and sanitation to the work of the self-help groups. And the chief resource person of the self-help women's group will then get trained on all these aspects. Once we piloted in Chhattisgarh, Telangana, and then Odisha, we'll scale it across the country in the most underserved parts of the country. Yeah. And another thing that we've done in nutrition is that, as I told you earlier, that in both Kilkari and Mobile Academy, we're going on to version 2, right? So we are going to have more emphasis on risk factors, right? So the one pilot we did on malnutrition, and it really worked well. And I'm going to bring it out here for the audience because focusing on nutrition. So what we found in the space was that if you wait for the child to become severe acute malnutrition, right, to get severe acute malnutrition, it's too late. It's really too late because then they have so many other medical disorders. They've already reached a state of no. I mean, you can hardly do anything for them at that particular stage. So you have to pick up children who have got moderate acute malnutrition, and that is currently not being done by ICDS because the way the program is structured, they pick up severe acute malnutrition children and then send them to the nutrition rehab centers, right? So we've done a program in Mumbai, which we hope is a model for the rest of the country, where we are scanning children, and since we have M-Mitra through the city, we can pick up those children because their mothers are already enrolled with us. We're picking up those children who have got moderate acute malnutrition. And then we're doing hand holding of those children, right? So the mothers are handheld by trained nutrition counselors who call the mothers for 4 months, right? So the idea is that based upon the kind of nutrition access they have at home, we will help them to develop proper diet for the child, right? Recipes, and nutrition and sanitation advice, right? So, and we're doing individualized hand holding of the mothers based on children's problems for 4 months, right? So what the idea is that we want to prevent progression of MAM to SAM, right? The child should not have severe acute malnutrition, get severe acute malnutrition. The child should get treated and not relapse, because currently what is happening is that a SAM child goes to a nutrition rehab center, relapses, gets treated for 8 weeks. It's supposed to stay there for 8 weeks, but it's very difficult for them to have a nutrition dense food. And then when they go back home, again they relapse, right? So the idea is to become much earlier and prevent them from getting SAM, right? So this program is an RCT supported by Grand Challenge Canada, and it's really worked very well. And we are hoping to spread it through the city, right, before we spread through the country. And our 5-year plan, right, scale-up plan is that right now we have 27 million women. The whole idea is to go to 45 million women through the country and their children, and train 1 million health workers, right, in the next 5 years. That's where ARMMAN is going. Thank you.
Thank you very much, Aparna. What a fascinating journey and very, very inspirational. We'll bilaterally connect. We are a technical partner to National Rural Livelihood Mission, and we are overlaying the FNHW program on the SSG collectives. And also, as you said, in the far-flung areas, we have seeded a program called Vibrant Villages program on the Indo-China border. And many of the technologies that you discussed today just, as you said, purpose fit there. So let me connect you bilaterally on this and intensively. For example, with CHETNA, we are working in Jharkhand with the National Health Mission, and in Bihar. There will be much for us to learn from you and extend some of these very impactful work to those geographies. And to the audience, this was many moments of inspiration. I was just wondering if I was at your age, I would have picked up 7, 8 inspirations, starting with, by the time we finish this panel, the numbers are staggering, and it is astonishing that in this day and age we have those numbers. 4 women would have died and 60 newborns would have died. That's what 90 minutes of India time means. And that should be an inspiration to all of you to, do something and create these purpose-fit technologies, as Aparna described, multiple technologies she picked up and multiple solutions. So I am sure all of us here would have been enormously inspired to, do more. You are the can-do generation, and there would be much for us to change the context. So if I could now, in some ways it is building up so well, from shared destiny that Induji talked about, to desires. ARMMAN is all about desires, and it has fueled so many sparks, so many desires in all of us to extend ourselves. Jaydeep, if I were to come to you and with a request to, you have something, fabulous. And I have known about your work in some ways as Aakar is. You give shape to both desires and destinies. So the way you have worked the model, we'd like to learn more about that in the way you work. But I guess there is enormous opportunity on what Induji was sharing or what Aparna shared in using the solution contour that you have developed, Jaydeep, in those contexts. So look forward to hear from you.
Thank you. Thank you for the opportunity to invite me here. And one of my partner participated in one of the sessions long back, and I think 5-6 years back. So happy to come back on the similar session. And I have been an MBA student also, so I could see like so many of you are here, like who could be entrepreneurs. So once when I was in college 10 years back, 12 years back, so I was also in one of you, like in positions like yours, and I used to listen to some of the seminars, and also have got a lot of inspiration from there. Now to talk about our journey, like we do not, just to give clarification, we do not work directly in nutrition, but then like the work we do had a lot of connections with that indirectly. So I'll try to talk about what we do, and then see like, and then also talk about the connections with nutrition, what we have. And I think like today I also learned a lot of things, and especially Aparna ji, like I would love to talk to you separately on this, and that the work we are doing through Aakar Social have a lot of connect, and we would it will be really helpful to connect with you and then take that forward. Now coming back to our work, so we have been working in the sector of menstrual hygiene over the last 12 years. How I started off, so I was since my college school days, I used to be working on some innovations, and then I also worked with a lot of NGOs in the healthcare sector and also in science awareness. And then I bumped upon and made some innovation. I got national international award, and then Dr. Kalam was president that time, back in 2004, and I met him and spent a lot of time, and then he connected me with Professor Anand Gupta, which some of you may be aware, who is a professor in IIM Ahmedabad, and have started network, so, and a National Innovation Foundation. So I started volunteering for them to work on grassroots innovations. People who do not know what is it, basically people who are not educated like us, like so-called degree holders, but then people who are in villages, in slums, or even in the forest areas, who have done fabulous work. Many times negatively we call them as jugaad, but then like such things like were women or men who have school dropout, college dropout, or illiterate, they come up with a lot of things like it could be a herbal practice, a farming practice, a food and nutrition solutions, or even a technology or a machine. So we, so Honeybee Network is to document them, and this has been called as grassroots innovation because this comes from the grassroots, and they face real challenges and solve real solutions. So I was doing documentations, scouting such innovations, about 1,000 of them I did. Then I realized like this should go to the market because it is being scouted, and some of them getting national award from president, but then like there needs to be taken forward. So I took that plunge and then started to selected some of the innovations. One of them was Mr. Muruganathan, who is famously known as Batman, if most of you would know the movie. So I took up his innovations and trying to commercialize it back in 2008-9, around that time. And so we set up a unit in the foothills of Himalayas in Khatima in Uttarakhand. It was a lot of learning for us. That unit and the machine didn't work for various reasons, but then the learning was like I came to know about the challenges of menstrual hygiene in the villages. Women are still using dirty clothes. We spoke to the doctors. They talked about like the women used to get a lot of infections, the white discharge issues, and that led to first of all spending a lot of money, and beyond that, the most importantly, people are getting died also, and getting disease which have implications for their entire life. So after learning that, like I thought maybe, although that, as I said, the unit didn't work, but then this is the area with I should focus on. The multinational brands that back then was not really working in the villages back in 2010-11. And now some of the, like, they have reached out to at least to the block level. So from there, I did some research, traveling across India. Outside India also I couldn't travel, but then I spoke with people, and then we came up with a machine to make sanitary pads back in 2011-12, which was a manual machine. From there we modified to semi-automatic, now automatic machines in between, another interesting thing happened, which I got an opportunity to go to Afghanistan and to work with Aga Khan Foundation as a consultant on the topic of menstrual hygiene. I had to lie to my parents to go there. Obviously, they couldn't have allowed me, but then I enjoyed there spending a month in the villages, a place called Baglan province, and then I did interacted with women there, only women in a workshop also while talking about menstrual hygiene, and they were very openly talked about this, their experiences and the challenges. One interesting thing I found there, like the sanitary pads are sold in the beauty parlors, which one of the key place where they buy it. From there, so I was posed with a challenge in Afghanistan itself, where they said that basically the senior people who were there, they said like, so you have doing good work, but then have you resolved the solution for the disposal problem of sanitary pads? Because I didn't had much idea that time with my little bit of knowledge back then. So I said, what is that? So basically they were meaning to that in the villages, in the cities, all of you have seen that sanitary pads are used, and then it goes to maybe an open dustbin where maybe a dogs or a cows will take it out and then throw it in the streets or maybe tear it apart. It creates a mess. It looks dirty, obviously not environment friendly. But imagine that same thing happening in a village scenario. The entire village gets to know about that, and it becomes a very big social challenge for them. So they said like, anyway, they're primarily their Muslim population. They have their own restrictions and social challenges. So they do not want to add one more challenge by introducing a product which would be more harmful for them. So then back then I came back to India and started researching, and then worked on making compostable pads in 2012-13. So you're the first company in India now globally, so to make that, and we have been working on this. We worked in different parts of India in 12 states, and also in about 8 countries in Africa. So whereas we set up this mini factories where women comes, like so from self-help groups, from small NGOs, from individual entrepreneurs, government, corporate CSR, they come forward and set up this units. We supply the machine, raw materials, provide training, ensure they are able to make quality products and also able to sell it. And this we have 2 companies. We call it as hardware software. So Aakar Innovations is the private limited company which works on the machinery, raw material, and the finished product. Whereas we have Aakar Social, which we call it as software. It's a Section 8 NGO, you can call it. So there we focus on education and awareness around menstrual hygiene. And there we have broadened it after our experiences that we call it now as behavioral change and communication program, where we not only connect, like this focus is on menstrual hygiene, but we connect with like sexual education, maternal health, then gender, life skills, all of that, because these are all connected with each other. And there I feel like nutrition has a big role to play. We don't have much experience with the nutrition, but then we do talk about like what are the things or the foods women or girls should have during the periods, like iron is what Aparna mentioned is a big challenge with the village women and girls especially. So I think that is something they need to be told. There are many things like beetroots and all, which if they continuously have it, so they can and then also adrak, like turmeric is something which we recommend them to use. But then I think we are still in a learning phase there to learn more. And I think we'd love to join hands with Aparna to on this particularly part, how we can enhance this experience with the villages, because we are extensively working with them and these are all connected to each other. Until unless we explain them, this is not resolved. Nowadays, unfortunately, this topic of menstrual hygiene has become very, very big across India and across the globe. But I think there are a lot of misinformation which has been passed on to the people, which creates more challenges because half information is not good. So we never try to give any half information or which we do not know. What we don't know, we say, yes, we don't know, we will come back to you. So that has been the thing. And then we have learned throughout the process and we are still learning. And I think the learnings will never end. And we learn from everyone, like, so starting from the village women, so who have taught us many things, and from like obviously people like you, people like Induji, Aparnaji and all. So this is the journey. And then now we have in fact also embarked to commercial operations where we sell our products in Amazon. And then a part of that earning from that, we take it and then we distribute free sanitary pads to women and girls across India. along with the menstrual hygiene education, because we believe without that, giving anything doesn't make any sense. So we have scaled up to almost 20,000 girls. We reach out every monthly basis across 5-6 states where we give this pads to needy girls and women along with this education program. And slowly we are coming up with more and more products coming up with menstrual cup, obviously with the diapers and all. So one of the key aspect of our products are as I mentioned earlier, we make compostable pads or compostable products. So which means there is a lot of fuss nowadays about biodegradability, but this is it's a scientific word, but very, very misleading word. Why I say that, biodegradable means anything which degrades naturally. But the unfortunate part of this definition is that there is no timeline to that. It can happen in 5 days, 5 months, 5 years, 500 years. All of this can be called as biodegradable in terms of technical definition. So there are a lot of people around us who are taking this benefit of this definition and giving products which are not environment friendly at all. So that's how there is no certification also biodegradability anywhere in the world. The subsets are there's something called oxo-degradable, which means where the materials or the products disintegrates into microplastics with ultraviolet rays, sunlight or heat, and becomes microplastics and remains as microplastics for hundreds of years. In fact, these are more dangerous than even the normal plastic pads. But this is also something which has been promoted, unfortunately, by many people. So, and this is banned. So oxo-degradable products or materials are completely banned from Europe for the reason of that, because microplastics, animals can eat, they can die. It can come to our food chain without knowing. We are actually eating plastics, which are very, very small, but then this is harming our body. We don't know. So this is one category. But the one which is scientifically environment friendly, I would say it's called compostable. The definition says within 90 to 180 days, the materials or the product will become part of the soil, disintegrate and become manure in composting conditions. Now, if the conditions are not made, it won't happen in 90 to 180 days, but it will happen within, let's say, a year or so, because these are core materials are all natural. Now, this is very, very important. It has international or national standards. So we adopted the Government of India standard. We are the first company to get the certificate. And then I am part of the Bureau of Indian Standard Committee for Sanitary Pads in India, along with Johnson P&Gs. And there, with this reference, they have made the new BIS standard for sanitary pad, which talks about the certifications. And we are trying to convert this also into other products, as I said, like baby diapers and all, which actually pollutes much more than a sanitary pad. So this has been our journey. And as I said, we have very little connections with nutrition directly, but indirectly, the awareness programs we do, there is a hell lot of scope there, and which we are learning. And we'd love to partner, as I said, Aparna-ji, with you after listening to you. Definitely go and get in touch. Thank you for this opportunity. Thanks, Ashish.
Thank you very much. And what educative. I never understood biodegradable and compostable are so very different. Fascinating. A management graduate addressing one of, at least in rural India, I know one of the most significant health challenge. Actually, menstrual hygiene is very closely linked to morbidity, loss of productivity, loss of income. So you are addressing one of the most important challenges, and it is linked to nutrition and well-being. And thank you very much. One, and follow on, if I may have, the mini factories, the model that you have, if you were to look at it in context of availability of nutrition, as Induji was saying, one of the challenges today in the remotest part, you have a Maggi or Kurkure,
yes.
And it is just at, as they say, a desire away. So, and it's like that. So if one was to make, healthy, nutritious, delicious food, again, a desire away, as they say. So how would mini factories, the way you have modelized the entire business process, would be helpful if you could share that. And I'm sure your, life journey would have, for me, many inspiration moments were there. I'm sure with our younger friends, they would have also picked on those inspiration moments. But on the mini factories, if you could share your reflections.
Yeah, so mini factories, the concept we built up, it was actually not our concept initially. Obviously, Ms. Muruganathan has started that, but we built onto that in a professional way, because otherwise earlier it was very, very unorganized. So we tried to organize it in a way, whereas we set up professional training programs, and then through that we train first of all install the machinery, we train the women, and also do a supervisor training after that, how they can professionally run it, and then maintain, like, first of all, the quality, which is very, very important. And equally important is the hygiene also, because if you don't maintain that, there could be challenges come up, like, but we are trying to prevent it, like we will only create that. So so that was a key thing. So although I would not say we have 100% successful there, but then we had our success as well as failures within that journey. And we learned a lot of things. Women have actually from the villages have taught us a lot of new things, like processes which we can make improve. And then, like, these factories are also become the hub in terms of people coming over there from all across the nearby villages, and then asking them what it is going on here. So when they said that this is sanitary pads being made, so when they see that this is happening, so it also becomes a hub for creating awareness in and around that area. And those women who are working in the unit, so they actually also have become the brand ambassadors of the concept, or maybe to promote this cause of menstrual hygiene and the health need. Because first of all, this is a necessity for every woman. And now, and also obviously it has connected with the men also, because so this until unless a woman is menstruating, no one will take birth. So it is, so in one of the conferences, I said that it is actually a area which is 50% of the population is directly connected, and another 50% is indirectly connected. So that important it is. But then, like, the challenge is that women and girls, and also the men and boys, they don't know about these things in the villages. And this has been like, they get information which are sometimes not correct or misled by religion, culture, and so many things. So what we did doing that is that, like, talking about the science. So what is the science? What is menstrual hygiene? What happens in the 28-day cycle? We try to talk about in a scientific way, but in a manner which they understand. We obviously involve a lot of doctors, because doctors are gods in the villages and they understand that. So we involve them. We also involve the teachers in the schools, because again, they are the ones who are connected with them day-to-day basis, rather than our team going and doing anything. We involve community health workers, Asha, Anganwaris, to do these programs, and which has created impact. But then a lot to be done. It's like still like drop in the ocean, but then we are trying our bit of things.
Thank you very much, Jaydeep. And I understand you're recovering from COVID, so this was really special for you to join the panel. So if I can now move to Suhas and Shivangi, I understand you have, there's a lot of interaction from the audience, and you could gather and cohere them into specific points for response by the panelists. That would be fabulous. Over to you, Suhas.
Yes, sir. So it's been a wonderful session from all of you, and I think it was very thought-provoking for all of us. Shivangi will now take up and ask the questions which the other participants have asked us.
Thank you so much for such a great discussion. We have a lot of questions. So the first one that we received in the chat is, a huge hurdle in providing proper nutrition during pregnancy and infancy care, especially in rural women, is the conservative families and frankly restrained upbringing of the females in the family. What are your thoughts on addressing this issue at the root?
Induji, would you like to take this?
That's actually the question I also had for Aparna, because, whenever we give information to pregnant women alone, they are not able to act upon it because they are constrained by the communities. And that is why we feel very strongly that you have to address communities, the men and people around them. Just giving information to pregnant women is not enough in our view, particularly, because they are the most disempowered in the whole set of things. So that was a question I had for her. We do it through face-to-face counseling and education, and we involve the whole entire family, because we see that the poor pregnant woman, especially if she is the primary, if she is the first very young pregnant woman, she is not able to act upon any advice that is given, because all the other community members have some kind of thing. Don't eat this, don't eat that, don't do this, don't do that. So we need to address all those too. We do it through interpersonal counseling. I'm wondering how this is done through an app.
No. So can I come in here? See, because I had to give a short presentation, I couldn't talk too much. I couldn't speak of the nuances around our program, right? So I told you very clearly, we have a tech plus touch approach. I completely agree. You can't have tech alone. You can't randomly take someone's numbers and send calls. We have a tech plus touch approach. I tell you what happens in face-to-face, right? And this is something that came from what I saw in Sion Hospital, right? You have extremely overcrowded clinics, no time to counsel women. You have to give, and pregnancy and infancy are very dynamic periods. Things change from week to week. Extremely difficult to go out to women as frequently as they need that information. And traditional models work on people going home to home, right? It's very difficult to create scalable parallel infrastructure like that, right? I mean, you have a whole ASHA network in the field. Now for an NGO to create a parallel health worker network of its own through the country becomes extremely expensive and not really cost effective. It's great to do in smaller areas, right? Now, that's why we always leverage existing health infrastructure, right? Now, even if we were to train ASHA workers, we're training the ASHA workers because the ASHA workers do not have access to knowledge, right? Because they train just once, 20-day training program, and after that, there is absolutely no refresher training. Our whole attempt in Mobile Academy is to train them better, right? So the more hand-holding, the more multimedia. We took over a voice call-based service, but now we are adding more multimedia, more hand-holding, more, more dedicated information if there are high-risk factors, etc. Same for the A&M medical office specialist. But even then, the ASHA can reach out to the women only when she goes home to home, when she has time, not when the woman requires it. That's why it's so important for us to add services directly to the woman, correct? Now, the thing is that we don't have just a voice calling service, right? It's also a callback send call thing. I mean, she's missed all the 3 tries. There's a missed call system, there's a call center. So that we have so many calls coming to the call center directly to ask questions. Secondly, the voice call not just for the woman. It's the husbands. You must realize the family phone oftentimes. And the husband receives the call oftentimes. And in fact, our content is tailored for both the wife and the husband, right? And the multimedia content that we have is getting created for Kilakari and Mobile Academy. Again, is tailored for both the husband and the wife. Right? That's the way we structure it. And more hand-holding of both the mother and the wife, husband, more high-risk factors are present. So that's how we do it. The thing is this, the point is this, we supplement existing efforts, right? So when we reach out to women so weekly like this, we're able to inform you on more and more simpler, smaller things, not just the big picture information, right? And you'll be very surprised as to how women, when they're handheld weekly like this, because they feel this continuous support, right? Which is coming directly to them, they become compliant over time because, because it's weekly, because hand-holding, it's an elder sister voice, right? And it's content on what they need at that particular point in time. It's time and targeted. And that's why these programs also add, Yeah,
Induji, and then I'll come with our own experience.
Aparna, I happen to be on the national mentoring group for ASHA. So I know a lot of issues about ASHA, and I've visited a lot of ASHAs. Actually, it's even not the husband who decides for the wife, it's the mother-in-law. What to eat during pregnancy, what not to eat during pregnancy, what to act, what to act. My always concern on the mobile phone thing has been this, because it doesn't change behavior of the people who influence the pregnancy outcomes. And I'm talking of rural areas. Bombay might be different. And
wonderful. So if I can come in, Aparna, and I think... Can I say
one thing? Sorry to bother you. You'll be very surprised. The uptake of Kilkari is most in Odisha. You'll be so surprised. The places where you have the least access to care is the place where Kilkari is doing the best. And as I told you, it's a family listening to the calls, not just the woman. And also everything adds together, right? You need a woman to be informed. I mean, I completely agree. You have to have complementary programs, right? Everything works together to have a information, the woman surrounded by the information that she needs, right? So it's also so important that the woman herself stands up to the patriarchy, which women do, if you give them the information. Yeah, go ahead.
So wonderful. And Shivangi has let us loose on something very important, actually, and right from, the way they say data, information, knowledge, insight, and meaning. So that's the transition that you do, and Thales work on nudges, particularly when we talk of very often, and we use IEC awareness and then shift to behavior change and practice adoption. So these are differentiated spaces, and you are right, the socio-cultural and spine of the society shapes that. Our work, for example, with CHETNA, where Aparna, we did, and it was a parallel program. And why you needed a parallel program was because Asha emanating from Jamkhed experience or the Mitani program of Chhattisgarh did turn out into an incentive. When government adopts a program at this scale, the incentive structures of the original and intent is diluted to a great extent. So what we have is something called Badlav Didi or Sachet Didi, as they call the SHG women, and a cross board. So it is both the cognitive and the affective nudges, as Thaler puts it in his eponymous work on nudge units. And that's where repeated. So today, for example, on IFA and Induji and IFA, mother-in-law says, my child will be dark. And the obsession with fair skin in our country. So we have to have a combinatorial approach. And Shivangi, thank you very much for putting this across. For us to realize a combinatorial approach using tech and Humatech, adding tech plus. And there's a very interesting work of Kentaro Tayamoa. If you can look up Geek Hearsay. Geek Hearsay is all about such technologies and in what context they work. He was Microsoft's research head in India, Kentaro, and his work, Geek Hearsay, would talk about some of this. So Aparna, I think there will be opportunity. There will be many more, such insightful observations from our friends. So
just one line I want to say, just one line. I completely agree that you have to approach a woman through multiple routes, right? So the reason we have collaborative self-help groups is that, right? In the most of us, you reach the women through multiple sources. Self-help, that's why we work with UNICEF.
That's the amplification. The combinatorial amplification through multiple mediums. And the example of Alive and Thrive in Bangladesh, which has done much better than our programs in India, is example use case for using multimedia, mainstream media, combinatorial technology, feet on ground, which removes the fog. This fog removes the other fog. So and you need all of that. So let's Shivangi.
So I'll take up the next question, but before that, just a notification to the audience. If you have a question, you can raise your hand or you can send the question in the chat. We'll take it up from there. So one of the questions that has come to us is that all the panelists are associated with one particular organization or many. For example, Jaydeep sir is associated with Aakar, Indu ma'am is associated with CHETNA, and Aparna ma'am associated with ARMMAN. So the question is, how did COVID affect the functioning of the organization during the time? And also the operational changes that you had to implement during the COVID time in order to continue the smooth functioning of the organization. And what role did technology play in the same? Anyone can take it up.
You have many rightly deserved accolades on that.
Yeah, in fact, COVID, everybody was skeptical of digital health before COVID, right? Because though we were showing, our program was showing impact, it's COVID that really brought out how digital health really works, right? So what had happened is that if you realize we do tech plus touch approach, we don't do only technology. So we already had a network of hospitals, a network of NGOs on the ground, through whom we approach the women, right? So when COVID struck, suddenly hospitals closed down or became COVID centers, and women suddenly did not have access to care, right? But pregnancy and infancy cannot wait for a lockdown. If you have an emergency, you need care immediately. Now to the call center, we were getting really distress calls, right? And the calls are coming in of a medical nature, not just logistic support. And so overnight, because we had this network, in a matter of days, we created a virtual clinic. So and a virtual clinic were manned by 60 pediatricians, 60 obstetricians, and morning and afternoon, we would have women calling in from all over the country. And in fact, our NGO partners use that virtual clinic of ours to take care to the women on the ground. So over almost 70,000 women, we had a two-tier system, right? You called in if you needed support, like, which hospital to go to, where an ambulance is available, linking to services, then we would answer that. Our staff would answer that. 70,000 women got that support, and 25,000 women actually got medical queries answered, right? Of an emergency nature. And the way we would support it is that, you had an emergency, we would validate it and make you go to the hospital and tell you where to go and ensure that the care was given there, because we had this network on the ground. And if suppose the problem was something that's solvable on the phone, then the doctor would give the advice, and then that staff would follow up. So this virtual clinic is working even now, actually. And that has actually led to the doctors say baatcheet with UNICEF in those underserved areas. Second thing is, because we had this whole mobile academy platform on the ground already, where we reach out to health workers, ASHA workers, we collaborated with the government, right? So almost 3.4 million messages being sent to health workers on the ground through the country, ASHAs, ANMs, and medical officers on various aspects of COVID care at different points, right? And even vaccine awareness, the Har Ghar, there's this campaign that government did. We were a part of it. We were the ones who did that voice calling to the health workers on the ground. And now what is happening is that COVID has become a chapter in our A&M training program, our medical officer and our medical specialist training program. Mobile Academy is going to have an entire COVID, section. And our multimedia, I told you that we're going to go into multimedia now, right? For ASHAs. The COVID chapter is the first multimedia chapter, right? So which will be then given to all ASHAs wherever we are serving. And also we will have face-to-face training in multiple geographies where we have state program managers stationed, especially in the north, right? So, and also we had COVID specific information. If you realize, second wave was very bad for pregnant women and children, right? So we have COVID specific information added to our voice calls, right? Hand-holding the mothers and children, right? So
wonderful. God forbid if there is a fourth wave, we'll be more adequately prepared. Induji.
Yeah, so we used the opportunity to develop modules on COVID for all the states that we were working in. And then we did a lot of online trainings. We also distributed ration kits, hygiene kits all over wherever we were working, and actually went and distributed those kits. So, actually healthcare, because creating health awareness is key specialty of ours. This is something time we used to really create awareness at all levels. And those modules which we have developed were adopted by many other states also. So that's what we did during the COVID period. But we started our work quite fast because we felt that there was loss of livelihoods during this time in the areas we were working. And so we tried to get them back on track by giving all these. Normally, we don't use that approach of, giving things, but we had to use this to give nutrition, food, ration kits, hygiene kits, and other, material that they needed. We did not stop even a single day actually working. So it was continuous. In fact, it was a great opportunity for us to, see how we can work under stress. So that's what we did.
Wonderful. Jaydeep?
Yeah, so for us, it was multifaceted. Actually, one thing happened in our production unit, which were generally didn't have so much of sales. So suddenly they started having so much of sales because pads were not available in the villages otherwise. So people were all crowding there and to get pads. So they suddenly had so much of demand, which they were not able to meet. But then we managed to supply them the materials within the guidelines also. And so they got actually a larger base of customer. That is one part of it. And on the awareness side, like we do a lot of awareness programs anyway, training of trainers, so that we had converted some of the parts into online modules where we organized and trained a lot of people, women actually, and men also across India. And so that they can continue the work rather than we doing, our team going and doing. So we train them and they continue their work in their geographies wherever they're present. A lot of organizations also reached out to us for providing sanitary pads to various parts. So we also, our production units also contributed that way. We also distributed a lot of sanitary pads to the needy women around that time. So I think these would be the things we did.
Wonderful. And actually, if I could add, at TRI, we just reinvented ourselves. On 28th March, 24th lockdown, 28th, we got an IAC. It was lockdown still, and from the good offices of the Honorable Minister of Commerce, we got the IAC. And we organized supply chain, and we started rediscovering the supply chain in China in terms of getting PPE kits, ventilators, and those were the primary things at that point of time. And by the time of second wave, we started learning on setting up oxygen plants in good 8 district hospitals. We set up oxygen plants in Jharkhand, almost 38% of the oxygen beds, and you are in Jharkhand in East Singhbhum district. We did, enormous oxygen concentration across all our geographies. We said that no one should die, with lack of oxygen. So apart from food relief, we reinvented ourselves into 2 hospitals in UP, one in Gonda, one in, outskirts of Noida. So these were some of the things that we had never done. We mounted a campaign to raise resources, close to 120 crores we raised to set up all these oxygen concentrators, oxygen plants, and equipping the front line. The first wave challenge was that the frontline workers itself were very reluctant to go out in the villages. So equipping them, making them aware, and ensuring that, and we discovered a new approach of working in the community. What we said is a kind of a neighborhood or a locality compact, where the women collectives, the panchayats, and the front line of the local administration came together. And that formed a social bubble in terms of ensuring triage, quarantine, and stuff like that. And so we actually rediscovered a new organization. Obviously, and our work went at X. We started partnering with the government in many states. So if COVID in some ways allowed us to discover what Induji has written, the shared destiny, or the ARMMAN and Aakar in us. Thank you. Shivangi.
So good to hear how the organizations coped with the pandemic and actually, implemented measures to strengthen nutrition in such a tough time. So the next question that we've been asked is, Poshan Abhiyan, or the National Nutrition Mission, promotes convergence among multiple stakeholders to strengthen nutrition on the ground. However, these different players have different approaches and different goals that they want to achieve in that time frame. So how do we strengthen convergence to achieve a nutrition secure India?
Induji, you are best placed.
Yeah. So actually, ever since our inception, and you knew my introduction, is that I strongly believe in convergence. I do not believe in working without converging, but it has been an uphill task. It is a very big uphill task, and but constantly one has to firstly recognize the role of the players in this. Often nutritionists think that, they are the only ones who can give the solution, whereas that's not the case, which I've realized long back. And, but unfortunately, ministries work in silos, and it is an uphill task, to make sure that where there's water, there is livelihoods, and the agriculture patterns are okay. Nutrition things, policy thinks that only giving information about nutrition will going to lead to a major change, and that is not the truth. So it's a constant battle, but convergence is actually the key. But how to do that? You have to constantly see what you can manage, because often for me, converging the secretaries of health and education and others was a stronger challenge than converging people at the ground. ANMs, Anganwadi workers and others, we always work with three together. We work at the grassroots level in a convergent approach, because we strongly believe that they have to work together. So I think one needs to start at the bottom, but the work at policy needs to continue, because if the policy is not, everyone, has this different, even funding agencies, for instance, everyone wants to take ownership of their funds. Someone gives a different DA, someone, doesn't want to do this. So we need not only convergence at the grassroots level, which we are doing with ANMs, Anganwadi workers and Ashas, but we need convergence at the top, and most important, convergence with funding agencies. In the morning, someone said, I think the keynote speaker said that, it takes 3 years minimum to, get a project into shape. Unfortunately, funding cycles are such that they don't fund for 5 years first time. They always say year to year, especially CSR. Often the funding pattern and the policy pattern doesn't help in convergence. But at the grassroots level, we always believe in convergence and try to give the same messages to the same people, the different sets of people. So the question is absolutely right, and I think it's easier said than done, but the top people need to sit together and do something about it.
Aparna, you wanted to come in.
Yeah, so I want to say here something, right? That the problem that we're always facing in our country is that we don't create comprehensive programs, right? When you talk about convergence, the roadmap to convergence needs to be laid out before we just force people to get together, right? And also funding needs to be for the right pieces, right? As Dr. Induji ma'am said, really, I completely agree that you just can't depend on technology without nutrition, right? I mean, you need to have access to nutrition for the mother and the child. And if you look at the funding of the government, right, and I firmly believe you can't be depending on CSR for nutrition. You can't be having, it has to come from the government. It has to come from the ICD scheme, right? And that requires almost 40,000 crores. And look at the budget, right? The money kept aside for providing nutritious meals to the children and mothers is half of what is required, right? Unless you have that basic gap, bridged, other things are not going to fall into place, right? So your budgetary allocation really needs to take into account the actual needs of the ground, right? Second very important thing is that you have to have a down-up approach, right? Your Anganwadi, ASHA workers and ANMs are not used to working together, right? If you go anywhere in the country, the problem is that they've been working in the silos for so long, right? And the amount of data they have to fill or the registers they have to maintain, they have not been integrated, correct? So convergence will happen if the kind of work that they do is integrated. What is expected to do is integrated, and that effort is required before we can expect them to converge. Right? I'll give an example. Right? You had a CAS application, right? Anganwadi workers had a CAS application which is there from years on. I mean, like which came in, and that app was supposed to be for digital recording of nutrition access and things like that, right? I mean, monitoring of the Anganwadis, right? Suddenly it was taken away in September 2020, and then they came up with the portion tracker, right? And Anganwadi workers countrywide are up in arms, right? Because the problem is that their problems while implementing services have not been taken into account. That's so you really need to, work very hard to understand the problems on the field, create, their workflow should be integrated, right? And not just a verbal integration on, I mean, I'll give a small example, right? If an Anganwadi worker does a survey in the field, that survey should then be easily, accessible to the ASHA and the ANM, right? You have so many different databases. They don't speak to each other. Everybody's going and doing surveys on the ground, and none of it is integrated. If the Anganwadi worker is just doing the, she does the family survey, right? And that survey gives you the eligible couples. And that data was accessible to the ASHA's ANM before them, without them having to go into the field again. That is the first step of integration, right? All of those things are not really happening on the field. Right, so there's so much more than just on paper convergence. Yeah.
So Aparna and Induji, and let me add my one bit into this. We conflate convergence, integration, synergy. Unfortunately, if you go on ground, and I once counted, and this was for a specific program which looked at Poshan. Poshan is a program of Women and Child Development Ministry. So I looked at, there were 81 such programs addressing nutritional issues. If you look at it from the public system side, there is a program, ICDS, WCD program. Then there is a program, midday meals, is an education department program. Then, and if you start looking at, at other programs, PDS, food and supplies, you just look at the ground. In terms of the administrative boundaries itself, they are not coterminous. That's where the problem starts. So there was, I had one conversation with the chief secretary in Madhya Pradesh, and he said, never talk about convergence. Always remember, the first 3 letters of this word are the most important. Con. It is a con job. He said, I cannot, you see, he asked me, what is the job of water resource development? The only job is provide irrigation to agriculture. I cannot get the head of the departments, the principal secretary agriculture and the principal secretary WRD to talk to each other. WRD has no other job. It is an input to agriculture. There is nothing else that they have to do, but still they don't talk. They have their own program. So now as we work with the National Rural Livelihood Mission, we have done some interesting exercise. I told them, just let's capture the district plans around economic development. You'll be amazed. There are 13. Irrigation makes a separate program, agriculture makes a separate program, horticulture makes a separate program like that. And then you have, so my my 2 bits to you, this our friends, do look up 2 things. There is now a very interesting work globally going around, something called government as platforms. Look at Estonia. Estonia is a country, it's a beautiful country, and look at how they are using to converge all government programs around on a single platform. And this is the new emerging field of public administration. The other thing I urge you to look at, and you should come up with solutions. This is a typical public, choice problem. And this has been for the last 100 years of bureaucratic engagements in the modern nation state framework. Look at a program which Tony Blair started called Whole of a Government Approach, WGA. And later on, actually, it was adopted in Malaysia, Pemandu. Najibullah, when he was the Prime Minister, he created a program on Pemandu. It was for government, integrated government services and delivery. Look at that. At the top, and those are small countries. India is a very large, it is a continent size country. So that is one set of the challenge. On the convergence bit, what Induji said, there is something called a Village Health and Nutrition Day, VHND. VHND is as a programmatic platform for AAA convergence, Asha, ANM, and Anganwadi convergence that exists in many of the states in Jharkhand itself, with some creative business process reconfiguration. Again, you should be looking at some of these things. At the district level, such reconfiguration is possible. And it does lead to, because a VHND platform exists, it does lead to convergence across the spectrum of health, nutrition, and care, quote unquote, silos. So we'll stop. I think we are at 15:48. Shivangi, Suhas, does that make it 90 minutes?
We can actually have 2 more questions.
Yeah, that's all right.
Wonderful. I just wanted to know before, and I should not miss my thank yous to such an excellent panel. Yes.
Yeah, so I'll go. We have a question for Jaydeep. Could Jaydeep talk a little about the economics of setting up the sanitary napkin pads unit and the pads? This was a question by Neeta Kejriwal.
No, so this is like a very, when we started off, we were starting at a very, very small unit, which used to cost like a few lakh rupees, like 2 or 3 lakhs. We went on to making semi-automatic version, which used to cost like between 7-8 lakh rupees. But now we are, what we realized is that so things has changed quite a lot, meaning like when we started working 12 years back, as I said in the earlier also, so there was hardly any sanitary pads available in the villages. But now the condition is that it's still, there are challenges, like only about 36% women use sanitary pads overall India at this time, as per the data. But then but there are penetrations, and then that's how it, at least at the block level, so pads are available from multinational companies. So why I said this context is that now anything you do at a small unit level, you should be comparable with the multinational brands in terms of quality, the price, and also the look and feel. So now which is a bit difficult to do it in a very small unit. So we then graduated ourselves to automatic setups, like automatic machine, which are state of the art and that can make pads anything comparable to any multinational pads which are made by multinational Johnson, P&G or anyone. So that unit goes up to 1 crore rupees, because that has capacity to make almost 200 to 300 pads per minute. And then like this, these are like the state of the art, like ultra thin pads. So that's how the setup costs become high, but then it have also the unit economics in terms of the scale. So the cost and the quality becomes lower than the small units, and then we can maintain that without indulging into much. So yes, this is the details. Anyway, I can share my email ID in the chat box. So if anyone have further questions to this, please reach out, and happy to take it forward from there.
We'll build on this, Jaydeep, your whole model of mini factories, and on the unit costs we'll pick from you, and could have wider replication opportunity across the country. Yeah,
so we have one last question, and the remaining questions, I believe, if it's all right with the panelists, can be sent to you and which you could answer. So the last question is for Aparna ma'am. It's from L Prabhakar. So is there a role for corporates to partner with ARMMAN beyond just funding, wherein there's a deeper engagement in identified rural geographies where they have strong presence? Ma'am, you're on mute.
Aparna, you are mute.
Yeah. No, we already do that, right? First of all, we collaborate with corporates in multiple ways beyond just funding support, right? We have this long-term AI collaboration with Google. I mean, long-term with Google.org internationally and Google India, right? And in fact, we've come out with models, AI models that are actually first, the pioneering kinds for the social space. So that kind of collaboration is going on with Google and also with Meta now. Right, so Meta platforms and whole amount, because we are working through WhatsApp now. I mean, the WhatsApp coverage in the country is huge, right? So now this whole collaboration Meta to use WhatsApp in multiple ways, right, to reach out to women with more handholding, more content, more multimedia, etc. So all of that kind of collaboration already exists with these kind of tech companies. Second thing that we are doing with tech companies, with corporates, is that you're very right? So a lot of corporates in their place of work, right? So for example, there are, especially in rural India, right, pockets where they work, and they're supporting local NGOs there, right? So we improve our enrollment into our program through their support, right? Because they do have on-ground programs, but they're supplemented by our programs and the enrollment happens through them, right? So even Kilkari enrollment has improved in multiple places through this such kind of corporate collaboration that we have. Yeah. And lastly, I must say that, yeah, I mean, we have a lot of people from the corporates. See, the thing is this, right? NGOs have to work with some amount of, when you have an NGO of the kind that ARMMAN is, right? It is public health, technology, scaled programs, right? And large scale implementation. It is very important to have various kind of skill sets to come and bear, right, within the organization, right? So we have people from various corporates who have actually come and joined us now, because those skill sets are very important for us. And within our steering committee also, we have corporate bigwigs who kind of support and comment on our strategy and things like that, right? So there's a lot of that collaboration going on with various corporates in the country. Yeah.
So if we can have just one last question. This is directed to all of you. What advice will you give to the new entrepreneurs aiming to strengthen nutrition measures among the rural community, given that the field is so complicated?
Jaydeep ji, let's start with you.
No, as I said, I'm not an expert in nutrition, so I think I would leave it to Indu ji and Aparna ji, because you are there. What we do, as I said, we are learning there a lot, and then want to integrate this as part of our programs, the outreach and awareness.
So what I would suggest, firstly, that you have to feel passionate about whatever you're going to do, and that is what will make you enter this field. And before you start anything, just go to the field and find out the issues, because actually, nutrition is different from toothpaste and Lifebuoys and other things. It is so region specific. One size does not fit all. What I'll talk in Maharashtra or what I'll talk in Gujarat is different from what I talk in other states. So wherever you plan to work, go and study that place thoroughly. You have to know the land, because if I say Puran Poli is good, everyone might not have that Puran Poli, and if I package it into Puran Poli, so it's not such a scalable thing. I mean, I'm telling you the truth. If you want really people to adopt practices, you need to know what they're eating, and therefore work, build upon what they're eating, rather than trying to develop messages. So I would strongly suggest that go to the communities you want to work and persistently, passionately and persistently follow your, but do work with communities before you come out with any solutions. I learned a lot from the communities, and I think that's why we've lasted 40 years, because we are constantly learning from the communities. Even today, I've learned a lot from all you panelists, and in the morning also. So constantly listen to communities, encourage them to talk of their issues. I have I'm telling you, I've learned from communities, and if you're able to address their issues, that's what you do. Don't go with a solution before you know your community.
Thank you very much, Induji. Solution changing a problem is not an entrepreneurial idea. Aparna.
I completely second what Indu ma'am has said. I mean, all that ARMMAN has done has come from my on-ground experience, right? I mean, and even now I'm a professor, right? So I am a full-time doctor and I run ARMMAN, thanks to my great team. But I'm a professor in Kama Hospital. I'm building a department of urogynecology. So I'm completely in the field even today, right? Because the thing is that the problem I found in the field is that the minute the organization grows, as a founder, you're no more going to the field, but it's so important for me to be in the field, right? And in urogynecology, I'm building a department of urogynecology at Kama Hospital, where every day I meet the same people we're trying to serve, right? Same women we're trying to serve, right? So it's so important to be second to the, women, children you're trying to serve. And that I completely second what Indu ma'am said. And one more thing I'll tell you, right? And I'm going to say this, right? It's important not to have a been there, done that kind of thing, right? Follow your passion. Not everybody has to be a social entrepreneur. Not everybody has to, create organizations. Not everybody has to leave the corporate, space that you want to enter and enter social sector. There's so much you can do from where you're sitting. Correct. There are so many examples of extremely great corporates who are helping us, right? I mean, the kind of collaboration we have with Google or with Meta, or even these steering committee corporate bigwigs who are there. They are completely in their fields, but then they're being able to kind of translate the learnings from there and help organizations such as ours, right? So, because when you're young, and I tell you, I tell you how it was, right? I did my fellowship in Stanford University, and there it was like the fashion, right? Everybody was creating organizations, correct? And then how many of them last? Because it's a lot of perseverance you require. You really have to sacrifice everything. Obviously, it's been so many years after which ARMMAN got recognized, right? That all those years of working on it, the perseverance, going to the field and creating solutions, putting your own money into it, all of that only comes in when you feel very strongly for a problem, right? So, and sometimes when you're 2 steps removed from the problem on the field, and the surrounding eco is like, okay, you go and build your own startups, right? Create a startup in the social sector, etc. Don't fall into that trap, I would say, right? Seriously, don't fall into the trap. Do what your heart says to do. Really, there's nothing wrong, right? I mean, every field you can take up is equally important, okay? I mean, social sector is no buzzword, right? There are so many problems and ills in this space, right? So all I'll say is follow your heart, follow your dream. If you find something that really resonates with you, run behind it. You don't even have to leave your job for it. Right? I have never stopped being a doctor. I've always been a doctor and built ARMMAN, right? Because if I won't be me if I'm not a doctor, right? So, so you can do both if you want to do that. You can enter social sector, but just follow your heart, right? There's no one size fits all, even here, about what you do with your life.
So, such wonderful life lessons. I have, I couldn't agree more with you, Aparna and Induji. We have to start from learning the users, the communities, and they teach you whatever is required. So nutrition and if I can plug in, we have done a nutritional food plate study across states and across regions, and we intend to bring quarterly movements on the food plate and its divergence from the NIN recommended plate. There are enormous opportunities in what you described. How do we get nutritious, delicious, affordable food to people? 70-80% is bought in now. But there are caveats. Mars and Tata Trust entered into an agreement to produce nutritious food. I was very closely involved with that. And today morning, Anand was there. I don't know whether he shared about this example or not. And that example didn't end as well. From the first meeting that Mr. Tata had with Mars and when getting the product, it was not picked up. There is another example, Mama. Again, this is a product in Africa, a nutritious product in Africa. So you will get a lot of ideas around take-home rations, around nutraceuticals. Those ideas are there. and those ideas are for picking. And as Induji said, but what will work, what will not work? It is a combination of a lot of perseverance, as Aparna said. Lage raho, jage raho, or seekhte raho. Then only it will, and as Aparna was saying, everything is meaningful, purposeful, as long as you follow your heart. That's how I'll describe. But if any of you are interested in doing these, and I'm sure Aparna, Jaydeep, Induji, all of us will be very keen to create opportunities for you to come and work with us, create such spaces. At TRI, we keep looking for ideas around enterprises. We have a whole program on mass rural entrepreneurship, and which is about delivering quality life services in the communities. If you are interested in making the ultimate nutritious food, which everyone in India, 140 billion of us will consume, 1.4 billion. So that's if we'll consume, all for it.
Yeah, same here. I would be very happy if people, you would like to intern with us, right? Yeah. We do have people from the management side and corporate sector who come and join us. People who, but I think it will be great to have management students, right? Early on coming in, if you can provide the exposure you need, it will be wonderful. Yeah.
Yes. For us, Shivangi.
So we move towards concluding the conclave here, and so thank you to each and everyone present on this panel. Honor to have all of you present in our event. Your participation ensured the success of the 5th edition of Social Entrepreneurship Conclave. We're delighted to host the most innovative brains in the field of social entrepreneurship in healthcare. We truly appreciate the speakers for sharing their invaluable experiences and speaking on pressing issues in nutrition and last mile delivery of healthcare. We thank our moderators for streamlining and carrying forward the discussion in a manner that helped us gain insights into the direction that future entrepreneurs can focus on in their respective journeys. We extend our thanks to our faculty advisor, Dr. Tata Raghuram. We are also grateful to Madhukar Shukla sir for his continued help in making SEC5 a success. We want to give special thanks to Father Paul Fernandez, Professor A.K. Pani, and Dr. Smithu Malhotra and the complete XLRI administration for helping us at every step of event preparation. We really hope the conclave helped highlight the issues prevalent in rural healthcare, and all of you were able to take away what you had intended from your attendance in this meeting. Thank you so much. Have a really good day.
Thank you very much.
Bye.
Great meeting everyone.
Yes.
And personal thanks to Aparna, Indu, and Jaydeep.
Thank you. Thanks.
And a big shout out to Sigma team.
Thank you, sir.
Thank you so much.
Thank you.
Thank you
Bye.
very much.